Good morning, one and all. After successful completion of 3 days of Endosynergy, we have reached to day 4, which is the last day of the Endosynergy 2021. Thank you, one and all, for the tremendous response for first 3 days. Today's lectures are also interesting with eminent scholars. I request Dr. Madhuri to take over.
Wishing
Dr. Madhavi, you're mute. You're on mute.
Wishing everyone a very good morning. Greetings to one and all. It gives me immense warmth and great pleasure to grace all of your presence for the Scientific E-Fest Endosynergy 2021. Before we begin, I would like to express my heartfelt gratitude to all of you who sincerely committed to this event to make it a grand success. Thank you for joining us for the last day of the E-Fest. I am glad to say the first 3 days of the E-Fest were graced with positive feedback from eminent people from all over India. Thank you, everybody. Thank you so much. It gives me tremendous contentment to welcome the most renowned personalities in the field of regenerative endodontics, Dr. Sai Kalyan sir, and one of the most glamorous endodontists, Dr. Mahima Tilakchand ma'am. I also welcome the speakers for the second session, Dr. Pratima Shenoy ma'am and Chairperson Dr. Dipali Shah ma'am. Dr. Pratima ma'am will be enlightening us on the teeth whitening lecture, and it will begin at 11:30 a.m. I know you all are super excited for the interesting topics to start. So without taking much of your time, I, on behalf of the entire team of Endosynergy, once again welcome you all. Now, I request Dr. Sonam Muthian to introduce our moderator, Dr. Mahima Tilakchand.
A very pleasant morning to one and all. I am Dr. Sonam Muthian, Associate Professor in the Department of Conservative Dentistry and Endodontics, YCMM and RDF Dental College, Ahmednagar. I take immense pleasure in introducing our today's chairperson, a lady with beauty, with brains, a very lovable and charming personality, Dr. Mahima Tilakchand ma'am. Ma'am, on behalf of entire Endosynergy team, I welcome you, ma'am. She is a professor, Department of Conservative Dentistry and Endodontics, SDM Dental College, Dharwad. She is a passionate teacher and academician with special interest and focus on regenerative endodontics. She has co-authored the position statements and Indian protocol for regenerative endodontics and has also written a chapter on the same topic in the textbook of endodontics. She has delivered more than 25 guest lectures and keynote addresses. She has presented her research findings at numerous national and international conferences like World Endodontic Congress, IADR, and EAC, etc. She has several PubMed Index publications to her credit. She was recently awarded the Most Proactive Academician Endodontics Award by the Guidant Jury. She is an active member of several academic bodies like IACD, IES, ACDI, and ISPRP. She is the editor of most coveted official newsletter of IACD, that is Pins and Posts. Apart from the academics and profession, she is an active humanitarian, loves exploring different facets of life, and champions various social causes, including women empowerment. Our HOD, Dr. Savisha ma'am, has added here that she is a very close friend of yours, and she has added here that Mahima ma'am is a multi-talented, a very charming personality, and she has seen your different cooking and dancing and extracurricular activities and a lot of social work you do, ma'am. We are extremely privileged, glad and honored to have you, such a great and dynamic, versatile personality joining with us. Thank you so much, ma'am, for sharing your time and knowledge with us. Now I request Dr. Mahima ma'am to introduce our today's speaker, Dr. Sai Kalyan sir. Over to you, ma'am. Thank you.
Thank you, dear Sonam, dear Madhuri, Sunanda madam and Sarvesha madam, and the entire team of MIDSR and YCCM for this wonderful opportunity. And the introduction which you gave, Sonam, was very heart touching and, very inspiring early in the morning to listen to. And it's a real great pleasure to introduce and moderate a session by a colleague, a close friend, and alumni of SDM, Dr. Sai Kalyan. So I've been given a biodata which I have to read about him, but like how Sarvesha madam added on. So I, would like to tell that Sai Kalyan is a very close friend, a dear colleague, and we have co-authored a position statement. And we are still waiting, Sai, to get it published before we start everything. So let me introduce the coveted speaker who has inspired me to be a part of regenerative endodontics as a major topic. So with not taking much time, let me introduce him. So Dr. Sai has done his bachelor's at SDM Dental College and has completed his post-graduation from RDC Pravara in Medical Sciences. Later, he did master's in advanced oral surgery and implantology, University of Bari, Italy. He also did his PhD in conservative dentistry and endodontics from Pravara Institute of Medical Sciences. He is also a fellow member of International College of Dentists, USA. He is a diplomat, Indian Board of Micro Restorative and Endodontics. He is an experienced academician with a rich work experience. During his professional journey, he has closely worked with several medical device manufacturing companies as their key opinion leader. At the academic level, he occupied various positions on the Board of Studies and Academic Council, Pravara Institute of Medical Sciences. He is presently the Chief Mentor for Regenerative Endodontic Department at Prerna Dental College, Navi Mumbai. He has actively monitored research at both graduate and postgraduate levels. He has supervised clinical work and conducted lectures for postgraduates and undergraduate students. And he has authored several research papers and has lectured at various national and international academic events. With this very, very brief introduction, let me present Dr. Sai Kalyan. The stage is yours.
You have to unmute.
You have to unmute,
Sai.
Dr. Sai.
Thank you, Dr. Mahima. It's great to hear all this early in the morning. In the industry, we don't interact so much. So it's really great. Share the screen now.
Yeah.
Loud and clear?
It's clear, sir. It's clear.
Yeah. I would like to start off by thanking all the organizers who made this happen. It's nice to be back into academics. We don't find a lot of time these days to devote to academics. This is one of the topics which is very, very close to my heart. We've been working on these concepts since the last probably 12, 13 years when it was in a latency stage in India. Now, a very large group of people are working on it and a lot of publications coming out of it. So today's topic is very, very close to my heart. This is one of the departments which I mentor at Prerna. It's got a dedicated department for regenerative endodontics. Me and Dr. Mahima also co-authored, along with Ruchika, co-authored a position statement for IICD on the same topic. This topic comes at a time when there is a slight decline. I would not say decline, slight disinterest towards endodontics among the public things. It might be slightly because of the advent of implants and secondary, the social media and OTP platforms like Netflix also airing a video. If you've seen this video, it's good. If you've not seen this, write to me, I'll send it. You can see how stupidly they have made this video. It was watched by millions of people, and they said that root canals can cause this, can cause that. The ADA and all the endodontic organizations had to go, and they had to stop broadcasting of this documentary on Netflix. So at a time when there is a slight decline, it is always good for a specialty because they up the ante and try to get in new ways of improving the profession as such. At this time when people keep thinking of implants, I am really grateful to such people like Dr. Ismail. You see vertical fracture on the mesial root, and then a lot of people would say, take it off, put an implant in. It will give you a better prognosis rather than preserving this tooth. You can see a beautiful radisection done in this case, properly restored, and it's got great prognosis. These days, I don't see people doing radisections at all. They rather pull it out and put an implant in. Eating on an implant is completely different eating on a natural teeth, because the natural teeth gives you that proprioception, where an implant will not give you that biofeedback and proprioception. So great. On the other hand, I see people doing these funny stuff. We call them ninja axes or cruise axes, whatever you call them. It's good if you have a CBCT and you do a CBCT guided axis opening, then this makes sense. Otherwise, doing endodontics without a CBCT guide would not do anything. And whenever I ask people who do these kind of things, like what is the major reason or the rationale behind such accesses, they tell me that it gives better fracture resistance. It's been proved day in and day out that conservative cavity preparation is good enough, and there are no significant differences between the fracture resistance of conservative access openings and the truss or the ninja accesses. So with two sides of the same story, you can say. I always used to think why we had a profession called conservative dentistry and endodontics. So as an endodontist, I always feel our primary goal is to basically save the pulp. And if we cannot conserve or save the pulp, then the later options of doing endodontic comes in. So it makes very sense why we named our profession conservative dentistry and endodontics. See, I started with this excellent article which comes from the Iranian study group at the University of Iran, Tehran. It says treatment outcomes of pulpotomy in permanent molars with irreversible pulpitis with biomaterials, multi-center randomized clinical trial. In this, the word you have to note is they put a word called irreversible pulpitis. Here we're not talking about pulpotomy in molars with reversible pulpitis. We're talking about irreversible pulpitis. We've been taught in our dental schools right from the beginning that irreversible pulpitis cases have to go through a root canal. And diagnostically, it is very difficult to diagnose a case with irreversible pulpitis. There's a lot of bias based on the experience of the clinician, the bias based on what kind of diagnostic tests are used, because we don't know the inflammatory state of the pulp by histopathological views here. We just do some clinical tests and brand it as reversible or irreversible. Most of the times we've seen that the cases are misdiagnosed, leading to unnecessary root canals. And in this article, they claim that they had a 95% to 98% success rate by by doing pulpotomies in tooth with irreversible pulpitis, which I think is a landmark achievement, which we should be proud of. So it's not just reversible. You can reverse irreversible pulpitis and preserve the vitality of the tooth. That's what this article means. So basically, this presentation is to shift you from conventional root canal treatments to a little on the regeneration front. The disclaimer is that we cannot do regenerative endodontics in every case. There is a strict case selection for this. This is not a replacement for routine endodontics. There are cases where you can do regeneration. There are cases where you have to do endodontics. So every case, probably you cannot use these concepts. The term regeneration, again, you can call it a misnomer or anything like that. We would rather call it maturogenesis rather than regeneration. So it would be apt to label our topics as maturogenesis of the dental pulp or maturogenesis of the tooth. Is this topic very novel? I don't think so. This topic is very novel because we've not added much to the concepts which have been there from the 1960s and 70s. The concept was put forth by a man called Nayagadosby, which many of you might be knowing. He's the man who got EDTA into dentistry, man who has his own rubber dam frames, and very innovative. He comes from the Scandinavian part of it. We see a lot of innovations and different thinking from the Scandinavian countries. So in this article, what he did was he created a blood clot at the apical end. Now what we call it a revascularization. So he did a prick at the apical area, let the blood come into the root canal space, and once it clotted, he did a sealing of the space. And then at that point of time, he was not subject to all these, what you call these, institutional ethical committees and ethical clearances. So he went ahead, extracted all those teeth, and he sent them for histopathological analysis. And this is what he found. He didn't find any pulp-like tissue in these cases of revascularization. He had seen cementum-like tissue, periodontal ligament-like tissue, and bone-like tissue inside the root canal space. But that started the whole concept of regenerative endodontics. He was quite closely followed by Nevin in the 1970s. He introduced collagen calcium phosphate gel inside the root canal space. You can see on the left in this picture that the apex is wide, right? It's an open apex. And he had injected collagen calcium phosphate gel inside the root canal space. And after a year, you can see complete closure of the root canal apex. If I publish this case in 2021 and say this is regeneration, a lot of people would say, wow. So this is a case from Journal of Endodontics, 1977. Okay, what has changed since 1977? Now, after 1977, not many people took this concept. A lot of people shifted to routine endodontics rather than regenerative. The whole concept was closed down for around 20-25 years before 2000, 2001, the American Dental Association and the American Association of Endodontics started taking it very seriously, and they put in a lot of money into this. So in 2000s, 2005, 2006, if you have seen one or two articles in a journal, nowadays you see a particular section dedicated to regenerative endodontics now. Since 77, there are lots of things which have changed. The irrigation is getting better and better. The disinfection part is getting better and better. Every day when I read journals, I see that we have lots of people researching on how to remove biofilms, how effectively and fast we can remove biofilms. From taking 20 minutes to disinfect a canal, we take just 4 or 5 minutes if we use the newer agents like the photoactivated disinfections or use of nanomaterials. Photoactivated has been proved to completely disrupt the biofilm in close to around 4 to 5 minutes, probably. We have data saying 90-second exposures will do. So the intracanal medicines have got better, surely. Irrigants, every month I see a new irrigant being published. So the irrigation gets better and better. We have better homing agents, that is scaffolds with our autologgers like PRP and PRF, which people like Niagara Dosby and Nevin did not have access to. We have better sealing agents. At that point of time, might be just zinc phosphate or zinc oxide eugenol were the most prevalent cements during that period of time, and cements which are not very hydrophilic, like glass ionomer. Now we have better materials which are more hydrophilic. They love water, and they can thrive in humid, wet environments. We have very strong coronal seals, better restorative materials at this point in time. Yes, the isolation was there then also, but the strict protocols laid down now, and there are new medical devices coming in every day to make isolation better and better. So what do we basically require? A lot of people say it is the tissue engineering triad, which has signaling molecules, cells, and scaffolds. But I would say it's a pentagon. All these 5 things are very important. Signaling molecules, the cells, scaffolds, appropriate environment. Cell signals and scaffolds will not survive if the environment is not appropriate. And the time required for regeneration is another factor. So these 5 factors are something we should focus on when we're looking at regenerative endodontics. This is one of my favorite slides on how to achieve regeneration. What are the things you need? So it's a very small story. It's a story about this guy, which we call him the cone head. To be a very successful human being, you need someone, a very close friend of you, who can tell you when you're wrong and when you're right, who can kick on your back and say, oh, boss, you're wrong. So to be successful, you need a very good friend who can tell you what is right and what is wrong. You need good access to food. You need good access to medicine, healthcare. You need good clothes to wear and a very good safe house to stay in. So similarly, to get the best results in regeneration and for a cell to be successful in regeneration, it needs something called a signal. It's like a friend which tells the cell what to become, an odontoblast, a fibroblast, or osteoblast, whatever it is. Cells should always be signaled to become what they want to. Just cells do not suffice. They need good scaffolds which they can thrive and live inside. They need good nutrition so they can sustain for a longer period. They need a very clean environment which is free of microorganisms, and they need a tight seal on top so that microorganisms or microleakage doesn't take place from the coronal end. So these are the things you need to have to achieve reliable, predictable, regenerative endodontics. So let's talk about these cells and gels first before getting into the broader aspects. Cells basically are the 2 types of cells. One is using stem cells per se, which is very difficult to get it into a clinical setup. An academic setup will be okay for it, but a clinical setup is very, very difficult to get stem cells into it because it needs proper microenvironments, it needs good sterility protocols, it needs a storage space, what do you call proper storage to maintain its state. The second strategy would be using something called signals. To home these stem cells into place, we have lots of growth factors which can do this. So these are the two strategies we can have. So people who are interested in doing something on stem cells, so these are the stem cells which are presently available. Human exfoliated deciduous tube, stem cells of apical papilla, stem cells from human exfoliated deciduous tube, bone marrow derived mesenchymal stem cells, adipose tissue derived mesenchymal stem cells, and so on. These are the four things we look at. So if you look at working in the pulp, the best thing I would say is focus on stem cells which are called SCAP, which is stem cells of apical papilla. People have done a lot of studies on shed. Shed is very good if you're looking at bone tissue regeneration or mineralized tissue regeneration. It does not contribute much to the pulp dentin complex. So SCAP is the thing you need to focus on if you're interested in stem cells in regenerative endodontics. So how do these stem cells know what to become? Because they have to know whether they have to create odontoblasts, lay dentine, or to create fibroblasts or whatever. So how do they know this? There are two pathways of how they know what to become. The one pathway is called the cytoplasmic pathway, and the other pathway is called cell-to-cell interaction pathway. Whenever there is a mesenchymal stem cell or stem cell which has to be signaled, there are certain signals which sit on top of the cell, and they relay the information into the cytoplasm. Again, the messages are again carried into the nucleus, where some genes are shut off, some genes are shut on or turned on, so that it can become a particular type of cells. So a message is conveyed to this thing through a signaling factor. So that's how it does. So to be elaborative, this is what happens. That's the cell. On the surface, you have something called a tyrosinase kinase receptor. This is a signal which attaches to the tyrosinase kinase receptor, and the message is conveyed to the inside, where the message is carried by the messenger proteins into the nucleus. Once the message is conveyed to the nucleus, then some genes are turned on based on what you have to become. If your cell has to become an odontoblast, some genes which are responsible for that function are turned on, and some genes which suppress that function are turned off. So a cell starts becoming a odontoblast. That's how it's not the perfect way of telling it. This is the easiest way of telling it. So this is the cytoplasmic factors. The second is cell-to-cell interaction. Sometimes it's proved that the cells interact with each other through a complex mechanism. So a cell which is undergone a transformation into a particular type of cell also passes information or signals to the adjoining cells, thereby telling them what to become and what to transform. So there is a cell-to-cell interaction happening, resulting in this kind of signaling. So what are the limitations with these stem cells? Is they're very, very sensitive. They need perfect microenvironments. They need very costly storage equipments. Might be store them at -80 degrees or -70 degrees centigrade. Not feasible to have these storage equipment in dental clinics, because it will be as costly as a dental chair. The third thing, it needs an oxygen carrier, an adequate sterility. It needs an appropriate microenvironmental mix. So these are the limitations working with them. Yes, surely possible in an academic setup. There's lots of research happening into using stem cells into endodontic spaces. Probably they'll come with a solution to these limitations. So the second thing is the scaffolds. These are the gels or whatever you need to inject inside the root canal space for the cells to thrive. And the ideal requirements is the scaffold should be biocompatible. It should be viable. It should encourage cell growth, cell attachment. It should degrade at the appropriate time. It should have biomechanical properties very close to that of the tissue. Among all these, I would say the degradation curve is the most important. The scaffold degradation must be in sync with tissue opposition. If the scaffold does not degrade in time, the tissue which is coming into the root canal space might not enter because there's no space or microenvironment to do regeneration there. So the scaffold degradation is a major factor you should focus on. There are lots of scaffolds in the market. We have inorganic scaffolds like hydroxyapatite, tricalcium phosphate, calcium pyrophosphate. We're not going to talk about inorganic solid scaffolds here. This is good for bone regeneration, tooth regeneration as a whole, for not for pulpal regeneration. So we're going to talk about injectable scaffolds, which can be easily injected into the root canal space, like PLGA or PGA or PMMA, all these kinds of scaffolds. The major drawback of having these chemical scaffolds or artificial scaffolds is that they're very good. They're easily injectable. You can occupy the root canal space in a three-dimensional pattern. But the major problem with this is they need nutrition, which has to be given externally, and they need some growth factors, which have to be put along with the scaffold here, so that it will encourage cell viability and cell growth. Right, so it's very good, but it lacks two things: nutrition and growth factors, which have to be augmented from outside. So what do? We always thought it is good to have a scaffold which is completely autologous. It's not artificially made, derived from the same human being. Like I said, completely autologous. It should have some homing agents or growth factors inside them so that they can form stem cells, which is already present at their apical papilla, make use of them, and then signal of regeneration. Right. So when we see this, there are two options we find is PRP. This is it's an age-old slide. One is PRP, it's platelet-rich plasma, which is completely autologous, can be easily made using a centrifuge, which hardly costs anything. And the other factor we have is PRF, which is platelet-rich fibrin. There are lots of names these days: CGF, LPCGF, or LPRF. The third one is what I love, is called the slow polymerizing platelet-rich fibrin, which people call it APRF also these days. So three things I would talk on: PRP, PRF, and APRF, or the injectable platelet-rich fibrin. Platelets, actually, when we do our undergraduation, we always told that platelets do just one thing. They help in clotting of blood, and that's it. But there are lots to platelets. When platelets are activated by thrombin or thromboplastin, they release something, right, which cause chemotaxis, proliferation, differentiation, angiogenesis, which are all components of regeneration or healing, right? So what do they release to get chemotaxis, proliferation, differentiation, angiogenesis? These things which they release are called growth factors. Whenever a platelet is activated using thrombin or thromboplastin, there are granules inside the platelets which are degranulated, and then you get growth factors coming out of them. Growth factors are signaling factors for stem cells. They play a very important role in regeneration and healing. So contrary to what we see under the microscope, regular optical microscope, we always think the platelets are disc-shaped. Actually, it looks like this. On the left, you have a platelet in an inactive state. On the right, you have a platelet in a complete active state here, right? In an active state, you can see these vesicles degranulating, and you can see all the messenger signaling growth factors being released into the space around it. So these will cause chemotaxis, differentiation, and all those things which are necessary for regeneration and healing. So these are some of the growth factors which are released by platelets. The most important of them is the insulin-like growth factor, which is a signaling molecule for stem cell expression. Epidermal growth factor is for proliferation, and the transforming growth factor is a key regulator in regeneration. I'm not saying the others don't do, but these are the important ones which I put it on this slide. So what happens if we do not have signaling factors and we just have stem cells? So this is an experiment, a famous experiment done at the Harvard Hughes Medical Institute. They introduced bone marrow into these rats, which were suffering from muscular dystrophy. In one rat, they just used bone marrow stem cells. In the other rat, they had bone marrow stem cells along with insulin-like growth factor, which is a signal. On the left, you don't have a signal, it's just the stem cells. The right, you have signals plus stem cells. And on the left, you can see the expression rate is very, very low. The thing in maroon, I'm not very good with colors, is the expression rate. You see, without the signaling factors, the expression is very low. Along with the signaling, you see a lot of expression here. So the signaling factors are very, very important because they signal these stem cells into what they need to do and what they have to become. So with this basic concepts, let us get into these two modalities of PRP and PRF. PRP is slightly a more complex thing. PRF is much more easier to achieve. And there is another modality which I will be talking, which is called the liquid phase platelet-rich fibrin, or the advanced platelet-rich fibrin, or the liquid phase concentrated growth factors, all of the same. So let's talk about PRP first. PRP is an autologous concentration of human platelets in a very small volume of plasma. The platelet concentration is 3 to 5 times the normal. The normal is 250,000. So it should have a concentration close to 1 million or 10 lakhs to call it platelet-rich plasma. How do you make it? I'll tell you in the later slides. This is the evidence of platelet-rich plasma. There are lots of articles where it has shown excellent results, and a lot of articles which they have shown ambiguous results, and there's some articles which have shown negative results. Because most of these articles do not have a standardized protocol for making PRP based on scientific evidence. So these are some of the articles which I picked up from the various journals. Here they say that PRP should be centrifuged 2 times at 2,400 and 5,600 RPM. This is an article which is PubMed indexed and so on. Whenever people talk about centrifuging, you should never talk about RPMs. It is the relative centrifugal force which you should be talking on. To be very simple, I'll tell you, if you have a very small centrifuge and you spin it at 2,400 RPM, it will create less force, centrifugal force. But if you use the same RPM in a bigger centrifuge, which has a rotor of 13 or 15 centimeters, you rotate it at 2,400 RPM, it will create more G force, right? Or the relative centrifugal force is larger. So smaller centrifuge at the same RPM will give you a smaller centrifugal force, and a larger centrifuge at the same RPM will give you a higher centrifugal force. So just be talking about G's and not about RPMs, as you've seen this. This is the mistake we make. We tend to copy this protocols as it is, right? And get varied results. So this is what we do. There are 2 types of rotors. This is a fixed angle or a swing out rotor. This is swing out probably. We have to measure the distance. This is the rotor inside the centrifuge. Distance between the center nut and the tip of the test tube here, the container here. So that's called the radius of the centrifuge. For swing out rotors, swing it out and then measure. For a fixed angle rotor, place a scale here and then measure the distance between that and the center. This is the radius. Then you have to calculate the RPMs using this complicated thing I put at the bottom. I would never do this. You can do it more easily. Go to website which is called endmemo.com. Here you have to put the radius of the centrifuge, which you have already measured here. And then the G-force, if I say what is the G-force required for PRF, the G-force required for PRF is 400. So when you put 400 here and 7 here and press calculate, it will give you the RPM required for that particular machine. So you need 2260 RPM to make PRF in this machine. Okay. If you have a larger radius, then again the RPM will keep changing. So this you have to do it only once. You need not repeat it again and again, right? So that's the thing. This is how I calculate my RPMs for a particular machine. So you should be doing this. PRP can be made in a single spin or a double spin. This is the single spin technique where you take blood in a test tube. You have to add an anticoagulant here for PRP, which is ACD, or you can use heparin. ACD is more preferred when you're doing regenerative endodontics. So you take blood inside that along with an anticoagulant and then centrifuge it to 460 G. Here I'm not telling you about RPMs. You have to calculate the RPMs based on your centrifugal machine. Then it will settle down into 3 layers. The layer in the center here, it's called platelet-rich growth factors, are directly pipetted and used. Okay, so here 1 ml you get platelet-poor growth factors, and then near the buffy coat you get 1 ml of platelet-rich growth factors. So this is PRP here. The second mesh technique of doing is called the double spin technique or the multiple spin technique. In this, what we do is we spin the blood. Okay, the first spin we call it a separation spin, where we separate the plasma from the red blood cells. Now, after the separation is over, all the thing from the buffy coat up to the PPP layer, the whole plasma thing is taken into another test tube, and we re-spin it at a higher speed. The second spin, we call it concentration spin, which concentrate the platelets. And what we, after the second spin, what we find at the bottom, all the platelets being pelleted. So that is used for regeneration, right? So the first spin is called the separation spin, which separates the plasma with the RBCs. The second spin is called the concentration spin, where at the bottom, all the platelets concentrate, and you take that to achieve your basic goal. So there are 2 things which we follow over the years. These are the 2 protocols. The soft spin is the separation spin. I advise people to use is 160 G for 20 minutes. And the second hard or the concentration spin is 400 G for 15 minutes. There's another low RCF protocol where 130 G we use for 15 minutes, and the hard spin we use 250 G for 15 minutes. Don't get confused. I'll show you a video which is more easily understandable. So the basic time required is 35 minutes or 30 minutes. So let's say 40 minutes is the average time you have to keep to make PRP. So it requires a lot of time. So this is the primitive method we used to use. Take 1 ml of citrate and 9 ml of blood into a syringe, put it inside a test tube, centrifuge it at 160 G for 20 minutes. This is what happens after the separation, right? Red blood cells pelleted at the bottom and the plasma on top. We take all the plasma and a very little of this buffy layer, right? see that you don't take much of the RBCs down, just 0.1, right? So, and then you put it into another centrifuge and then you concentrate it again at a higher RCF, which is 400 G, for close to 15 minutes. And this is what happens after the second spin. This is the coffee coat and the little RBCs which have gone during collection. The bottom 1 cc is your PRP and the top is your platelet poor plasma. This is what you have to use for your regenerative endodontics. 1 ml is big in endodontics. You can fill all the 3 canals and still you'll have some to spare, you know. So that's PRP for you. This PRP stays in a liquid state for a considerable long amount of time. When you want it to become a gel, you have to add something like calcium chloride or thrombin or thromboplastin. Once you add calcium chloride, thrombin, thromboplastin, you get 5 minutes to inject this gel, inject this liquid inside the root canal space. In 5 minutes, the liquid turns into a complete gel. So you need an activator here. So before activation, whenever we make PRP, we count the number of platelets. You can use an automated cell counter, or you can use a new burst chamber to count. The platelets should be at least 3 to 5 times. The ideal would be 1 million per microliter. So these are the activating agents we use. One is thrombin, thromboplastin, or thromboplastin, and the other is calcium chloride. Since this liquid, once you put it and activate it, you can see it gelling in less than 5 minutes. Completely forms a 3-dimensional gel. And you can see that 3-dimensionally has filled the space inside this plastic container. So how long can you keep this? 8 hours in non-activated mode. But once you activate it, you just have 10 minutes, less than 5 minutes to put it into the root canal spaces. So the second generation is called PRF, which is more popular because it does not require any anticoagulants here. You just take blood, put it inside a test tube, and then spin it for 10 minutes at 400 G. You get a clot in the center. You can see this clot in the center, which can be taken out and put it into the root canal space. Personally, I'm not a big fan of using PRF inside the root canal space because it is very difficult to push a membrane into a constricted space. So these are the things which most of you must be knowing. PRF has certain advantages. It is a slow release membrane. It releases growth factors in a sustained manner, but PRF releases growth factors very quickly. Then PRF is completely autologous. It does not require any anticoagulants. PRP requires some anticoagulants, and it requires some artificial agents to activate it, like I told you, calcium chloride, or bovine thrombin, or thromboplastin, whatever. So here you can see that in a PRF, the release is more sustained, but in PRP on day 1, there is more. And as you go, you can see in the red ones, as you go, the release of growth factors become less and less. In PRF, the growth factors actually are more and more sustained. You can call them sustained release ones. So it's very good. You can see the blue one. First day is less, second day it goes up, third day it goes up even higher. Like 7th day it goes up, and 14 days goes even higher. 14th day is a very important day when you think about healing. So it's got the peak at the 14th day. So this is how you get your PRF inside a test tube. The center part is your membrane. You can just pull it out and use it. So it's a more easier protocol. It takes just 10 minutes, 10 to 12 minutes when you compare it to PRP, which takes 30 to 35 minutes. So that's the clot. That's the diagrammatic view, right? There's so many concepts and so many ways, so many commercial products are available in the market. PRP is a concept. We have something called CGF made by a machine called Medifuse. We have APRF or PRF made by a machine made by Shukran's group. And then you have LPRF, you name it. There's a big list. I can put 4 slides on the list of PRFs and PRPs available on date. So my present focus is to make something which is in between a PRF and PRP. It has the benefits of both, and easy to inject and better results and require the least amount of time. I would say liquid phase growth factors is the best, or you say IPRF is good, right? Injectable PRF is good because it takes just 5 minutes to make IPRF, or LPCGF 10 minutes it takes to make. It is in a liquid state. You get 5 minutes to inject inside the root canal space. In 5 minutes, it auto-coagulates and becomes a gel, right? So that's very good here. Again, best part is no anticoagulants. So it is completely autologous, best of PRF. It has more growth factors than PRP and PRF. The second one. Third one is easy to inject and it gels in 5 minutes, which is good enough for root canal spaces. And the best part is it can be just made in 5 minutes, not 10 minutes like PRF and 30 minutes like PRP. So these are the advantages of using IPRF. IPRF cannot be made in normal tubes. It requires special tubes, which are called Z tubes or non-additive tubes. These are the 3 tubes which you have to consider when you are making PRP or PRF or IPRF. For the IPRF, we need a Z tube. The color might change for different companies, but you have to look at this called Z tube or no additive tube. This is for IPRF. You spin it at 60G for around 4 minutes. You get IPRF there. PRF uses a test tube which is coated on the inside using silica. You can as well use a glass tube because it's calcium borosilicate. So silica does the trick there. And in this test tube, the red test tubes. And if you're using PRP, I would rather go for an ACD based test tube. If you're using PRP for face, for wrinkles and all that, you can go for a heparin based tube. But if you're using for regeneration, endodontics and stuff, you can think about ACD. So that's the test tubes you have to keep in mind. You can buy it over the internet, available a lot of online platforms. So the injectable PRF, it's so easy. This is how they collect blood. Easy system here. It's called the Vacutainer system. Okay. See here the tubes are orange, but they are no additive tubes or the Z tubes. This is using IPRF machine, or see that it's already done after 5 minutes. You can just take it out and it gels in around 5 minutes. It starts to gel, completes in around 12 to 15 minutes. I don't have an endodontic case here. This is case shared by one of my friends, Iziogeno. Right, that's how you collect all that. Okay, let's not get into this. Okay, you can see that's the bone graft. You can use this for this thing. Now we have added the bone graft on plate, and then you put IPRF on this and let it sit for around 5 minutes. And after 5 minutes, the whole thing gels down. You can see this gel forming here on top, and the whole thing gels into a single mass. Okay. While putting inside the root canal space, you can just inject it without any biomaterial. So it gels into a 3-dimensional space. If you have to add something to it, if you're innovative enough, you can add something. So we talked about cells, scaffolds, and combinations of cells and scaffolds. Before going into antibiotics, for intracanal disinfection, irrigation, tooth factors, and the coronal seal, let us learn what we have learned from the past so that we can incorporate those learnings, make a better protocol. This is one of the first articles published by Mohammed Torabenejad, where we used PRP inside the root canal space. He said that he had a positive vitality after a period of time, which was challenged by some Indian researchers also. But however, the treatment looked successful from an open apex to a closed apex. After a year, he did a histopath of this, and he said that he had something which is called pulp-like tissue, right? So the same protocol with minor changes was used by Gabriela Martin, but in this article, she says she didn't find pulp-like tissue, but she found a periodontal or cementum-like tissue inside the root canal space, much similar to what Nyaga's Osby had found. Right. The article which is the best in the field is by Dr. Nakashima. Her group had used stem cell per se inside the root canal space, so you can see pulp regeneration happening, three-dimensional pulp, which is lined by odontoblast. In the other cases, we do not find a three-dimensional pulp inside the root canal space. It's just pulp-like tissue. So when we use stem cells per se, you get a three-dimensional architecture inside the pulp canal space. So that's the dream of the dentist, is to get three-dimensional pulp inside the root canal space. So what confusion we have is, are we getting pulp-like tissue? Are we getting periodontal ligament-like tissue? Now, with the present protocols, are we going to use stem cells to get a three-dimensional pulpal architecture? It's a big confusion. So I would say that we have something, which is something called the mermaid phenomenon, where we're not getting total three-dimensional pulp. We're getting something which is close to pulp, which we rather say it is healing rather than regeneration. It can be renamed as a concept of maturogenesis or healing rather than calling it regeneration per se. What Nakashima achieved here, we can call it regeneration completely, because she regenerated the same tissue which was there before that, replacement of one kind of tissue by the same kind of tissue. That's what is regeneration. This is what Dr. Nakashima has achieved. Okay. Let's see why these two articles I've showed you about Mohammed Torabenejad's article and Gabriela Martin's article. One had good pulp-like tissue, the other had bone, this kind of tissue. What is the problem is normally when we're doing research in the Indian subcontinent, it's rather we pick up an article directly and follow what they've done, okay, blindly. And when that researcher fails over a period of time, we also end up in failing along with him, right? So whenever you find some research, collect multiple articles based on that research, and then read more about the articles where people have failed or got undesirable outcomes, analyze why they've got undesirable outcomes, change your protocol so that you can get past those barriers and get reliable results, So don't follow the articles blindly, put your logic into it, develop your own protocols so that you get reliable results. Based on all the articles which have been published, the irrigation, intracanal medicaments, everything is better, but still we're not getting great results because we don't understand the existing modalities in an appropriate way. So we have to develop new approaches and develop better understanding about the existing technologies which are in place. So we talk about a little about every technology. The pulpal status, Before, we used to say completely remove all the pulp from the root canal spaces if you are doing regenerative or revascularization. Now, the present status, if there is vital tissue at the pulp at the apex, leave it as such. Conserve as much as pulpal tissue as possible. So, how do you just remove the necrotic pulp and save the vital pulp? I'll tell you in the later slides. The apical states, it was understood that 1.1 mm is the minimum thing which is required as per the TCNA 2012. But now we always thought that was too high. An 80 or 100 micron would be more than enough. Might be 200 micron must be more than enough. That is 0.2 millimeters, 0.3 millimeters of X. This was reinforced by this article which came in 2013, where they said a 0.3, 0.4 apex is good enough to achieve regeneration up to the pulp chamber, right? So this has completely changed. Then based on disinfection, the gold standard has been hypochlorite and all these. Every day there is a new technology. We should be adopting newer, faster technologies. Hypochlorite, the Gabriela Martin's article used 6% hypochlorite, thereby killing all the apical papillary stem cells, thereby not getting pulp-like tissue inside the root canal space. That's why she got that kind of tissue where it is periodontal or bone kind of tissue. So you have to replace it by 0.5 to 1% sodium hypochlorite. The beauty of this hypochlorite, it dissolves just the necrotic, leaving the vital tissue there. So you can preserve as much as vital tissue inside the root canal space. I should always activate these irrigants to get faster results. You can use it using sonics or ultrasonics. Here you have a sonic device. The second irrigant is 17% EGTA. It's a very good thing. A lot of people use this. It does two things. It chelates, removes the smear layer, and then it exposes the trapped growth factors inside dentine, which are called PMPs. So thereby enhancing regeneration here, because cell attachment is better when you do this treatment with ETTA. But the contact time is what we miss. A lot of people, even we as postgraduates, when we started, we just gave it 1 minute time to act. So a minimum of 5 minutes stay time for ETTA is important so that it gets the proper outcomes. Chitosan is a very promising thing. It does two things. Yes, it removes the smear layer like EDTA. It also chelates. Then it does another thing by cross-linking the exposed collagen fibers, which is an excellent thing. So chitosan is something you have to think. Citric acid conditioning of dentine is also very popular these days. They say the number of cell viability or cell attachment is higher when we use citric acid as a conditioning agent in regenerative endodontics. You can see that citric acid has larger number of migrated cells when you compare it to EDTA or phosphate buffer cell line. So 10% citric acid is an effective solution with a conditioning time of 5 to 10 minutes. Chlorhexidine, yes, if you want to use it, but I'm not a big fan of chlorhexidine in regenerative endodontic cases because it's proven again and again that it's not much effective in stubborn biofilms. 2% chlorhexidine can just destroy everything. It's too toxic for the apical papillary stem cells, as shown in this thing. So if you're using chlorhexidine, you should be using it at 0.12%. Chlorhexidine, not the 2% thing. 0.12 is not good enough for endodontic disinfection, so might as well think when you use chlorhexidine in regenerative endodontic cases. There are lots of strategies other than chlorhexidine to disrupt the biofilms. So this is again a very good thing. It's not in the market, but it's the dream irrigating agent for regeneration because it has tetracycline, which is an immunomodulator, and a bacteriostatic agent, or it's not completely bactericidal. Then it has an acid which is citric acid, as I told you. It does the best for cells, and it has a detergent which reduces the surface tension and gets the best out of the irrigant. So the differentiation has been high when MDAD has been used inside root canal spaces. We have also tried photoactivated disinfection inside the root canal space, toluidine blue, methylene blue, tactochartosan inside the root canal space, and 100-second exposure would destroy most of the endodontic biofilm bacteria. Destruction of biofilm is very high and very fast using photoactivated disinfection systems. This is some of the studies which were done. This is a study done by one of my PGs, Pujanata, using silver nanoparticles. A lot of us have collaborated in this work. So you can see complete root canal disinfection, and the dentinal tubule is also green where the biofilm has been disrupted. Now the promising is plasma. There's no device in the market. It's all experimented, but since it is third matter, it would be a very good solution for disinfection of endodontic spaces. Antibiotics, basically triple antibiotic paste is very popular. 3 weeks of triple antibiotic paste is what we do. A lot of people have talked about stopping minocycline because it discolors dentine and replacing it with lots of other stuff, you know. Some have put cephalosporins, some have put amoxicillin, but you don't need a third antibiotic here. Ciprometro are good enough. If you're replacing minocycline, you should be replacing it with immunomodulator like triamcinolone acetate. So minocycline causes upregulation of rank-rankle OPG mechanism, exposes collagen fibers and growth factors, inhibits MMP, collagenases, and it's a very good immunomodulator. These benefits you cannot get with the other replacements which are there on scientific articles. There is some literature that this is a little toxic, so you should be looking at pharmacy colleges to make the right concentration of around 50 micrograms per ml. It's also postulated that 1 mg per ml calcium hydroxide paste is good enough to disinfect the root canal space in 3 weeks. So that's the thing. You see the cell vitality with calcium hydroxide is very high when you compare it with the triple antibiotic and the double antibiotic base. Second thing, we see that the unfavorable acidic condition as a result of using tetracycline hydrochloride, ciprofloxacin hydrochloride, results in less regeneration, and alkaline environments are better for regeneration. It's an age-old Indian science which is reinforced here. So that is one of the reasons might be calcium hydroxide. It's got better results in these articles. Being a very alkaline agent, it takes the pH to a higher state rather than having an acidic pH inside the root canal space. So the drawbacks of minocycline can be rectified by coating the inside of the crown, the chamber space, using a 7th generation bonding agent. Please plug the orifice with Teflon before coating this, or you can add a little of flowable composite resin on the pulp chamber, right? Plug the orifice, coat one layer, and then you can put the intracanal medicament in. By coating one layer of bonding agent, we are closing off the tubules there, so there is no way that discoloration can happen in the coronal space. So this is one way which you can avoid discoloration when you're using triple antibiotic paste containing minocycline. The last frontier is choosing the right coronal material. I'm not going to be an industry specific advice. I use different MTAs at different situations. The ProRoot and the Angelus I love when I'm doing obturations. These are very powdery, grainy. I love the MTA Plus and the Biotin, which have got that putty-like consistency, easy to carry and use. Regenerative endodontics, you need something like putty consistency there so that you can put it on top of the fibrin clot which you are doing. So this is the thing. So this is what I use, MTA Plus. It has a gel and a powder. When you mix, it gives you a putty-like consistency, just like your zinc phosphate cement, which can be condensed into the root canal space like that, right? So if you have a powder-like consistency, this tends to happen. It flows into the root canal space. Very difficult to control here. This case was done using a barrier, and the other case was done without using a barrier. So, okay, let's come to the most interesting part after this boring theory session. So this is what we questioned when we started doing regeneration cases. Why should we replace the pulp with a plastic substance rather than retaining the vitality in the radicular portion? So we took some cases of irreversible pulpitis which had all four walls remaining because we were scared about micro leakages happening in one wall and two wall missing, right? So these were cases which were taken irreversible. The coronal pulp was removed, and then we put platelet-rich fibrin here. It is a pulpotomy case, just like the first slide we discussed about the Asghari Irani's group. And then we put MTA over that, and then we topped it up with glass ionomer and composite. 6 months, we saw complete healing at the apical area, which completely healed in around 18 months here, right? We uploaded this case, IJ, at this point of time, they're not completely satisfied. Again, at 22 months, we re-uploaded and then it got accepted in 2012. This was the first pulpotomy using platelet-rich fibrin ever published. So we thought, okay, it must be one-off case. So we did a series of cases, and every time we did with the same protocol, same results. We got overexcited, did some cases. This is a case, one of my PG had contributed, Dr. Dairishi. This case, we used PRF in over-retained deciduous tooth. Right, you can see again the same protocol, PRF, MTA, and then GIC, and then over that, a stainless steel crown paste. Excellent results in these cases too. These are some cases from literature using platelet-rich fibrin inside root canal spaces. Okay, the results are fine, but I always found it difficult to push the membrane inside the root canal space. Rather, I would use IPRF or LPCGF, which are easy to produce and syringe, and within 10 minutes, you get a three-dimensional gel inside the root canal. So I would rather go for the advanced versions now. PRP, this is one case we did, case where we had open apices. These are the case selections. The apices should be 0.4 to 1.1. Younger, the better. Patient should not have any bleeding disorders or should not be on anticoagulant therapy. The patients of periapical surgery are not to be taken up for this kind of treatment because there is no Hertwig's epithelial root sheath because we tend to remove the apical 3 mm in episectomies. So this is the case selection you need to take. The total protocol is in 2 visits. The first visit we do access opening, removal of pulp, disinfection, and put an intracanal medicament. In the second section, we put PRP, a barrier placement, MTA, and a triple C. So basically 2 sessions, which are apart by around 3 to 4 weeks. So this is how the case came in on OpenApex. Access open, I'm seeing a lot of people doing small accesses. OpenApex need slightly larger accesses. Okay. This is what we did. And then we did disinfection with sodium hypochlorite. It's just 1%, as I told you. The volume is around 15 to 20 ml. Then EDTA we use for 5 minutes. And then chlorhexidine we didn't use. You have this thing. We did photoactivated disinfection in this case. And we put triple antibiotic paste and sent it back for 3 weeks. Some of the postgraduates might ask me how to make 0.51% hypochlorite from 3% hypochlorite. This is the formula you need to use. I think this will be on Facebook, the whole lecture. There's lots of lectures of mine on Facebook. You can take this formula and then calculate what amount of water to be added to make it a 1% or a 0.5% solution. Okay, we agitated the sodium hypochlorite inside, and then we used EDTA for 5 minutes, put triple antibiotic paste. Before putting triple antibiotic paste, we seal the tubules inside the pulp chamber. Yeah. And then we send the patient back for 3 weeks. And when the patient came back after 3 weeks, we checked for tenderness on vertical percussion, any periodontal pockets are present, any sinus tracts. If sinus tracts, periodontal pockets, and this tenderness on percussion was negative, then we go with the second setting, where this is the first setting. Second setting, no, that's the first setting. The second setting, we have to draw blood. So you go in concentric circles to swipe out all the dirt here. This is the age-old one. I'll show you the latest one also. Okay, put a tourniquet on. That's called a butterfly. Okay, put it there. And then put a tape on top of that. See, you're very careful, or the blood starts dripping there. This is one problem with this technique. Then attach a syringe with citrate in that and collect another 9 cc into it. 1 cc of citrate in this. Okay, this is the primitive method. We don't use this anymore. We use something called a vacuitainer technique, where you put a tourniquet, clean the side, and then we use a BD system, vacuitainer system. See that the bevel faces up. Okay, go into the vein. You can use something called a vein finder, which is a light which can easily tell you where your veins are. Right? See, the blood comes there and stops because there is a seed here. Once you put a test tube on it, the blood starts flowing. Okay, there's a complete seal system where you don't.
How do we keep the follow-up? And how do we check for the progress? Okay,
Yes, sir.
Sai, your video is muted. Voice is muted.
Now, yeah. So once the blood is collected, it is centrifuged in 2 phases. I told you there is a 2-step centrifuge. This is again the primitive method for people who don't have access to vacuitainers. The first spin is called the separation spin. separates in two layers. So we leave the RBCs at the bottom and just take the plasma along with a small buffy coat here, which makes the plasma a little red when I take it into the centrifuge again. Yeah, see that? This, I'm going to put it up into another test tube. It is slightly red because of the buffy coat layer I took. And again, spin it second time at a higher RCF for 15 minutes. And at the end of 15 minutes, this is what you get. The bottom 1 cc is PRP. Once you get your PRP, you have to activate it. I told you we have to use calcium chloride, thrombin, calcium gluconate, thromboplastin, anything. So I've taken calcium chloride in the syringe, taking PRP. Just mix it a little, and then you're ready to insert inside the root canal space. So in 5 minutes, this liquid turns into a gel, and because of the activation. Then you place a collagen plug there on top of that, and then you put a MTA, which is putty based. This is MTA plus. Thing we like about this is when you manipulate, it's not grainy. It is more putty, and it can be easily carried into the root canal space with normal carriers. Do not need any special carriers here. So you can see this MTA barrier which we have created on top. Because of the collagen, it's a flat barrier. So it's very important to use barriers. So that's how it progressed. Don't expect results within 1 year. If you have a patient older than 25, 30, if you have a 12-year-old, 13-year-old, probably 1 year would do the trick. So that's complete closure at the end of 1.5 years. This is what we did. Visit 1, we took an informed consent. Okay, we gave local anesthesia. Rubber dam was placed, and then the root canal systems were accessed, and then the working length was determined. And then the root canal system was irrigated with 0.5 to 1.5 ml sodium hypochlorite, 30 ml in the canal, 20 to 30 ml per canal it is, for 5 minutes. It is agitated also to increase the efficiency. EDTA 20 ml for 5 minutes. 20 ml for 5 minutes. After this is done, the canals are dried with paper points. And then the tubules in the crown portion is sealed with either 7th generation bonding agent or with flowable composite. And then a triple antibiotic or calcium hydroxide is placed. If you're placing calcium hydroxide, there's no need to seal the tubules in the if you're using triple antibiotic with minocycline, then you have to, after temporary restoration, here, when I say interim restoration for 4 weeks, I'm talking about glass ionomers. I'm not talking about zinc oxide based temporaries. Then second visit, as I told you, we look for swelling, sinus tracts, percussion, and periodontal pockets. If they are nothing, then we go to the next step of or the second setting, where we give long-acting anesthesia here without adrenaline if we are using revascularization, because if you're initiating a clot at the apical area and you have a vasoconstrictor in your anesthesia, it's not going to bleed. So if you're doing revascularization, use anesthesia without epinephrine or adrenaline. If you're not using that, you're just injecting PRP or putting PRF, then might as well go for your normal LA. Here we don't use hypo on the second visit, we just use EDTA because the canal is already free from the biofilm or the bacteria. There's no need to go for hypo again. Canals are dried, PRF is placed or PRP is placed. There is a concept of using bleeding along with these treatments. Yes, you can do a combination therapy. Once the bleeding is induced, if bleeding is induced, once the bleeding is induced, you must allow it to fill, and then you place a barrier on top of it, and then there's this a collagen barrier on top of it. And like I showed you, we place at least 3 mm of MTA in the coronal area, and you have to put 2 more layers over it, glass ionomer and composite, before you finish off the case. The case needs to be followed at 3 months, 6 months, and yearly for a total period of 4 years, right? Don't expect any magic in the first 1 year. Yes, in young permanent teeth, yes, the results are even better because the regenerative capacity of the individual is higher. Don't expect this to happen in an individual who's 45, 50, 55 years of age. We did pulpotomies and maturogenesis. Is this 100% perfect? No, we got some undesirable results. This is one case which we did with the PRF pulpotomy protocol. Okay, and see, at 6 months, we found an internal resorptive cavity, right? So we're very scared that we lose this case. At 12 months, the cavity stayed put. Again, in 24 months, you can see the internal resorptive cavity stayed in place, it didn't progress, it stopped like that. So this is one undesirable thing we got. Probably there were some mistakes we did. I'll discuss about those in the coming slides. The second undesirable outcome we found in 15 to 20% of cases is obliteration of root canal spaces. You can see almost 20 to 25% we found this problem. In this case also, we found obliteration on one side, slight obliteration. You can see on top on this side. So these are the undesirable outcomes we found. In the central incisors, we found a hard barrier forming in between. That is, we thought it was undesirable, but now there's much evidence that there is a barrier which forms there to ward off the infection which comes from the top. So what was happening is the internal resorption was a consequence of odontoclastic activity happening there. This odontoclastic activity starts off when there is a high amounts of inflammation. You know, inflammatory status is high. The odontoclastic action starts. Okay, so we thought, okay, if we can lower the inflammation to an acceptable limit, we can stop this odontoclastic activity. So this is one thing we learned from this. High levels of inflammation can trigger off clastic activity, leading to internal resorptive cavities. The obliteration is again based on the autonomic regulatory control. In the event of injury or high inflammatory states, the odontoblasts and the mesenchymal stem cells go bonkers and they don't know how to behave. They start laying dentin irrationally, leading to obliteration. So you have to carefully monitor this over a period of time. So here also we found that if we can reduce the inflammation to a slightly lower state, you need not take the inflammation off, because some amount of inflammation is necessary for healing and regeneration. So you have to get it to a lower level. So how you get it to a lower level is by signaling some growth factors called the TGF beta, transforming growth factor beta. The TGF beta is a key player in stem cell pluripotency, and it's a proper signal which it also can reduce the inflammatory states. This can be activated by putting low level light. Okay, so 3 nanometer lights, which are flashed for a period of 3 minutes. These lights can be lasers or can be LEDs. So the recipe for the future is using low-level lights, using new disinfection protocols, using photoactivated disinfection nanomaterials. More research has to go into that, using the injectable or the slow polymerizing PRFs, which take less time and have better benefits. Standardization of your centrifuges is vital, because that is one thing which can standardize your protocol. Otherwise, there are researchers in the Western India who are using a different centrifuge. People in South India are using another centrifuge. In eastern part, they're using different, and north they're using different. So we cannot compare our studies because we're not following a proper protocol. So if next time anyone asks you how do you make PRF, you say I spin it at 400 G for 10 to 12 minutes. That's how I make. Don't say 2,700 RPM for 13 minutes. If they ask you how do you make PRP, then you say you do two things: 130 and 250, 140 and 400 Gs. So you always talk in Gs. This is how they come to know that you know more about these regenerative modalities. So this is what I advise the younger ones to follow. Benefits of both PRP and PRF using LPCGF or the IPRF. These are made by specialized machines. You can program your centrifuges. If you're planning to buy a centrifuge, please buy a centrifuge which can show you RCFs. Okay, not not RPMs alone. Okay, so we have centrifuges which you can toggle between RPM and RCF. You can program it that way. And they start 35,000, I think, go up to 60,000. And the bigger ones start at 1 lakh, go up to 3 lakhs. So this is what we are looking at right now: growth factors in albumin scaffolds and non-autologous. We always been talking about autologous. This is my next presentation, which is coming. I think I will take a break on this topic for quite some time till I get the results out on these non-autologous options, so the albumin scaffolds. So these are the take-home conclusions. Failures are good. They tell you where you have to improve, and these improves are the clues. You have to incorporate these clues into your protocols. Use signals, because those are the ones which are very important. Use low-level lasers so you can regulate the amount of inflammation here. Use newer disinfection modalities. Don't follow the leaders. Don't download articles from internet and follow them blindly. You can probably make a concrete protocol based on your own views, and then put them into practice and see whether you can get better results. So we always say that the climb is steep, but we are halfway through. It's just the last thing we need to do to get a complete three-dimensional pulp. So analyze, put science, evidence, and common sense together. Just don't follow the leader blindly. Don't follow the master articles blindly. So this is my tip for better research in this area. So that's how we don't want a mermaid anymore. We want a complete three-dimensional pulp kind of a scenario in future. Thank you so much. I think I bored you quite a lot. Thanks for listening to all of us quite some time. But Mahima would be completely bored.
No, I'm not.
It's been second or the third time she's sitting.
I think more than 3 times. But Dr. Sai, that was an amazing and extensive insight into regenerative endodontics. And I'm sure the PG students and all the faculty who have attended today's lecture will be highly beneficial by this talk. There are certain questions. So could I just pose those questions? Are you ready to answer them?
Yeah. Go ahead.
Okay, so the first question was, for open apex cases, what do we prefer? MTA or PRP and PRF, or both?
Okay. MTA, PRP, PRF, or both. Okay. MTA, you mean single step apexification?
I think that's what the person who has posed this question means.
If there is enough remaining dentine thickness on each side, you can go for a single step MTA epexification. But most cases where you have thin walls on both sides, it's always better to do a regenerative protocol or a maturogenesis protocol where you increase the thickness of the remaining dentine at the apical area, which increases the, or it improves the prognosis of that kind of tooth. PRF or PRP, I will not comment because it's your thing. But I would advise to go for injectable PRFs, IPRFs, or liquid phase PRFs, because they're easy to handle and they have been proven time and time again to contain more growth factors than PRP and PRF alone. So that's the way to go, I feel.
Yeah, and I also agree with you about the IPRF because a few cases we've done now, and we've got good results with IPRF, as well.
Protocol.
Yeah. So the next question here is, it's a good question. How do we keep a check for progress, or what are the criteria which indicate healing?
Okay. At present, yes, on the periapical signs and the clinical signs are the only thing we can do. You can do a periapical index. Probably we wrote a chapter on that, using a periapical index in keeping a record. You can use a CBCT and a PAI together to keep a record every 6 months. So it has to be closely monitored for at least 4 years in patients above 20 years. Probably below 20 years, you might get results between 1 to 2 years time.
The next question is, what is double seal and triple seal?
Okay, it's just nothing. If you read the Ray and Trope article, Martin Trope's article in 1995, I'm not very good with dates. It says that the coronal microleakage is more problematic and leads to maximum root canal failures. So he emphasized that the apical seal and the coronal seal are equally important. He said that if you do a very good endo and a very poor coronal seal, the chances you might fail is 60%, right? But if you do a very good apical seal and a very good coronal seal, there is a 95% chance of success. So the coronal seals are very important. So the MTA is what we put. And on top of that, to be double sure, you add up glass enema on the same visit and send the patient. Some people don't have access to resin modified glass enemas, so you can put chemical set glass enemas on top, send the patient. Next day, you remove a little of glass enema and add composite on top of it. So it makes a triple seal, MTA, glass enema, and composite on top. If you have resin modified glass enema, you can finish it in one sitting. MTA, RMGIC, and composite over it.
And the another question is it mandatory to place a crown after regeneration in posterior teeth?
It's $1 million question.
Yeah.
Even in the case we published, we got a little scared after 12 months that, oh, we are up for publishing, so we should. So you must have seen my case also, I put a crown. Based on how much tooth structure you lost, based on how much, if it is 4-walled, there's no way you're going to think about it. If it is 1 wall missing, 2 walls missing, it's better to have a coronal restoration to go with.
And I think this is the last question. How to be sure of the disinfection?
Yeah, we have a big joke we say when we are in the industry. It's very good to make disinfectants because the end user will never know whether it is efficient or not efficient. So the science is based on the research which is already there. So this is 1% or 1.5% sodium hypochlorite or 5.25% sodium hypochlorite if used in a canal for this amount of time can cause eradication of biofilms. It's been done again and again. There's so many systematic reviews, meta-analysis done that strength works. So you just have to believe that it works. Yes, you can take a paper point thing and then culture it, but it takes 72 hours for the culture to come back. It is good when you're doing routine endodontics, but regenerative, you don't have that amount of time. Second, here in normal endodontics, you don't have your body's immune system take care of it. Here in regenerative endodontics, you have cells coming inside, so that will take care of the phagocytic action inside the root canal. So don't worry too much about it. If you go with that amount of irrigant, as I told you, 30 ml, so 20 ml sodium hypochlorite, probably postgraduates would use 20 ml sodium hypochlorite in the whole day. So 20 ml sodium hypochlorite in the canal for 20 minutes will surely reduce the biofilm to an acceptable limit. On top of that, you have intracanal medicaments to take care of the leftover biofilms. So that's a good enough protocol to disinfect.
Thank you, Dr. Sai. And I think we can, any more questions can be mailed directly to you. And we hand over the case situation, now the presentation to our organizers.
Thank you so much, sir. Thank you so much, ma'am.
Yeah, thank you, Dr. Sai Kalyan. It was a really good lecture, very informative lecture. And thank you, Dr. Mahima, for your wonderful contribution.
Sorry, ma'am, Pratima, ma'am. I made you wait.
Welcome, Pratima, ma'am.
No.
Welcome, Pratima, ma'am.
I was hearing you and very pertinent. Actually, we all are into saving the natural teeth. So I think your topic and my topic is also like, I am also speaking on bleaching, save the nature, save the natural teeth. So I think it was a very good talk. It's always a pleasure to listen to you, no doubt on that.
Welcome, ma'am. We have a small token of appreciation for you. Please accept it with our sincere thanks.
Thank you.
Thank you so much.
Thank you so much, ma'am. Thank you so much, sir. Now I request Dr. Praveen Dhore to give the vote of thanks.
Very good morning, all of you. My name is Dr. Praveen Dhore Patil, reader in Department of Conservative and Endodontics in MIDS Dental College, Latur. First of all, I would like to thank my department and my college for giving me this opportunity to express my gratitude on the very special day. I would like to take the opportunity to thank our very scholar speaker, Dr. Sai Kalyan sir, for delivering such a wonderful and informative lecture on regenerative endodontics. And I would like to thank Dr. Mahima ma'am for adding valuable insights on the topic. Last but not the least, I would like to thank the entire Endosynergy team for this Endosynergy 2021. Thank you.
Yeah, thank you so much, Dr. Sai Kalyan and Dr. Mahima.
Thank you.
It was a wonderful session for us. It will be definitely beneficial to the students as well as to the faculties. Yeah. Thank you so much.
My pleasure.
Who doesn't like to be beautiful? In the past, only movie stars had the opportunity to bleach teeth. Now cosmetic dentistry has gone ordinary and easy. To elaborate on this topic, we have our beautiful Dr. Pratima Shenoy ma'am with us, who will speak on the topic, if smile is power, tooth whitening is to empower it. I am glad to welcome you, ma'am. The session will be moderated by Dr. Dipali Shah, ma'am. I cheerfully welcome to you, ma'am, too. I request Dr. Sonam Muthian to introduce our moderator.
Good afternoon, one and all. Myself, Dr. Sonam. I take immense pride in introducing our today's moderator, Dr. Dipali Shah ma'am. Ma'am, a very warm welcome and greetings to you from our entire organizing team. Ma'am is a professor and head of department, conservative dentistry and endodontics at Sihaga Dental College, Pune. She has 20 years of experience, undergraduate teaching experience, and has been a postgraduate guide since past 9 years. She has completed her advanced courses in medical education technology and research methodology from MUHS Nashik. She has served as a resource faculty in more than 15 workshops in medical education technology and research methodology. She has keen interest in using education technology for both UG and PG students. She has over 20 publications in peer-reviewed journals to her credit. She has been invited as an invitee speaker at Endovista, Mumbai, and AFMC Medical College, Pune, and a few more. She is a section editor for Journal of Conservative Dentistry. She is also a reviewer for various specialty journals and has actively reviewed bioignition grant proposals for Department of Biotechnology, India. Her current research interests include biofilms for dental caries, for which she has collaborated with National Chemical Laboratory, Pune in this field. Additionally, she is currently working on cellulose-based formulations in endodontics. Ma'am, all the very best wishes for your extensive research work, and we are very much grateful that you have joined us and shared your valuable time and knowledge with us. Thank you so much, ma'am. Now I request Dr. Dipali Shah ma'am to introduce our today's speaker, Dr. Pratima Shinoy. Over to you, ma'am. Thank you.
Thank you, Dr. Sonam. And I congratulate Dr. Sunanda Gadale ma'am from MIT, MIDSR, and Dr. Sarvesha Bonve madam of YCMM and RDF Dental College, Ahmednagar, for organizing such a splendid program for all of us. I'm here to introduce you Dr. Pratima Shenoy ma'am, and she's going to talk on tooth whitening. Whitening always reminds me of the snow and the mountain tops, which are snow-capped. And snow brings in this virtue of kindness and bliss. And one person, I think so, who can personify that is Dr. Pratima Shenoy. Thank you, ma'am, for joining us.
That's a huge compliment.
No, I have always seen you, met you, and it really feels so nice. It actually shows on your face, ma'am. So I think so you personify kindness to me.
Thank you.
Well, let me introduce Dr. Pratima Shenoy to you. Yeah. Pratima Shenoy ma'am is a well-known name in endodontics in Maharashtra as well as in India. She is professor and head of department at the VSPM Dental College and Hospital in the Department of Conservative Dentistry and Endodontics. She heads a robust department, I should say, and she has a lot of vivid teammates who are very active socially, academically, and also in research. They are always at the forefront in all types of activities related to endodontics and conservative dentistry. I think so that shows the spirit of Pratima ma'am and how she spearheads her department. She has 78 publications, national and international publications to her credit, and she is heading 10 ongoing research projects with grants from DST. She has registered 3 national patents in her name. They are on gypsum products in dentistry and its environment, herbal decontamination of toothbrushes, which she patented in 2018 with Government of India, and GP Herba Care 2018. She has also contributed to textbooks. She has contributed to dental laboratory procedures by Rudd and Morrow, and she has contributed to textbook of endodontics. We have all read in Dr. Mitra Hegde madam's textbook. She has many honors to her credit. She has, I think so, Nagpur is her Karma Bhumi. She has been a topper during her BDS tenure at Nagpur University. She is also the first lady president of GDCH Nagpur. She has pioneered in establishing the Endo Herbal Garden, and she has hosted the first ever online Congress in endodontics. And we all know that we all benefit from her 1 hour, 1 minute online lecture series, the E-Link Fest, which happened so successfully into 2020 and 2021. They were really good academic boosters, ma'am. She has been an invited speaker at various national and international conferences. She's been active on the radio as well. She has broadcasted radio talks at the All India Radio for the program Arogya Dhyan Sampada. She has won first and second prizes at the Avishkar MUHS based research competition, and she has many awards and accolades to her credit. She has won the Best Individual Performer Award at BSPM Dental College and Research Center in 2013 and 14. She's won the Famden Special Jury Award for her academic excellence in 2019. She has won the Indian Health Professional Award for Excellence in Research in 2019. She has won the OCHRI Award of Excellence in 2020. And she has also won the Connexon 2020 Award of Excellence in Undergraduate Teaching at the 5th International Dental Congress in Mumbai. She is a reviewer for many high impact and index journals, including our very own journals, Journal of Conservative Dentistry and Endodontic Journal. Such an illustrious and exemplary role model is there with us, and she's going to give us her talk on smile is power and tooth whitening is there to empower it. Thank you, ma'am, for joining us, and we are waiting impatiently to listen from you and please share your knowledge and your views on tooth whitening with us today. Thank you, ma'am.
Thank you so much, Dipali, for a very elaborate and very humbling introduction. Actually, of all the things I think I owe to all the people I met on the way who have inspired me, and all the beautiful women of our Endo group who keep inspiring me to do better and better. So I think it is nothing personal. It is all because of what I have learned from others. So thank you so much. And I think I'll share my screen.
Yeah, thank you, ma'am.
And we'll start. Is my screen visible?
Yes, ma'am.
Yes, ma'am.
It's visible.
That lovely introduction, actually, I'm feeling so speechless. But anyways, first, let me thank the organizers for giving me this opportunity to speak and express my views on this particular topic. And my special thanks to my dear friend, Dr. Sunanda. We know each other since our PG days. So the association dates back to almost 30 years now, near about 30 years. So it's been a pleasant journey. And Dr. Sarvesha also for being so kind and so nice and giving me this opportunity. Thank you so much. And Deepali for that wonderful introduction. I owe you a treat when we meet. Okay. Thank you so much. So coming back to my topic, if you see, I have titled it as If Smile is Power, Tooth Whitening is to Empower It. So we all know today that smile is one of the most non-verbal communication we have with each other, anytime, anywhere. Whether it is a small child or an adult or someone you know, you don't know, any age, any race, any religion, smile is one thing which will connect you to the individual person. And therefore, smile plays a very important role in every individual's life. We have this belief also that if a smile is good, healthy, and happy, then the person is very healthy and he is approachable. So with this in mind and the social media acting all over. We have these beautiful smiles which we keep seeing every day, and social media has affected us so much that today we believe that having a good smile is the only solution to all our problems, because it is now been ingrained in us that it's the looks that matter, or it is the way you express yourself with a smile that matters. And therefore, a smile has had a greater impact on everyone. Since this social media has reached every nook and corner of the globe and the earth, I can say, this is not limited to the privileged few. Even people from the villages and the small places are now wanting to improve their smiles or improve their aesthetics so that they are able to communicate with the world in a better way. That is the thinking, I think, that has been generated, and that is why we are running after this particular thing of having beautiful smiles. One study conducted in Iraq has reported that there is about 300% rise in people wanting to brighten up their smiles and wanting a better smile. So after tooth extraction, that is like for patients seeking treatment for painful tooth. Earlier, it used to be tooth extraction. Now we are not extracting teeth anymore, but patients seeking treatment for pain in tooth is one side, and the other side is patients seeking treatment for aesthetic rehabilitation of their smile. So today my topic is on bleaching of vital teeth. So I'm limiting my talk on bleaching only of vital teeth. Also, I would like to tell you that throughout this lecture, I am not going to deal with the very theoretical part of the topic, which I am sure the textbook will do more justice to. And neither I am going to show you how to do a particular type of bleaching, because we have obtained numbers of videos on the YouTube and Facebook, which will give you a better idea and show you step by step. However, I would like to share with you certain things which have not been included into the textbook per se, because we generally take this treatment protocol as very simple or very easy, and we do not invest much time in it. But to all the aspiring clinician and all the students, I would like to say that vital tooth bleaching is one treatment which does not require much investment from our side. At the same time, it gives you humongous goodwill and feedback from the patients. So if you are able to change the smile, I think you have won the patient forever. Like the patient keeps coming back to you again and again. So before I even begin about bleaching, I would want to tell you that there are two different things in tooth bleaching. That is, one is tooth whitening and the other is tooth bleaching. Though we keep on using these terminologies to and fro, but tooth whitening basically deals with removal of the stains that are on your tooth. The natural color of the tooth will remain the same. Whereas on tooth bleaching, the natural color of your tooth is lightened, and we try to remove whatever intrinsic stains are there, or the stains which have changed the color of the tooth or which has dimmed the color of your teeth. Coming to the natural tooth color, we all know about natural tooth color. I am not going to go in detail. I just want you to know that there are certain things which we cannot change. Like that the tooth is darker cervically. No matter which tooth, it will remain dark cervically. So if there is some patient who is more bothered about this, I think you have a limited scope of doing bleaching in this particular patient. This also is a known fact that the thickness of the enamel and dentine will tell you about the color of the tooth. If you get a patient whose enamel is very thin, because of various causes, there are limitless causes of thin enamel or the defective enamel. If the color of the tooth is different because of this particular defect, no matter how much bleaching you are going to do, it is not going to change the color of the tooth. Then we know that enamel is blue, and it is the dentine, yellow dentine, which is more responsible for the color that is there in your tooth. So this dentine yellow is what we would want to mask if the enamel is very thin. Your bleaching is not going to help in that, because the enamel is translucent and it is going to keep showing the dentine like more yellow and yellow the more you bleach. Canines and the teeth behind it are much darker than the teeth in front. And lastly, we should all know that the teeth will become dark with age. So if the patient you have treated at the age of 23, 24, he comes back to you at the age of 35, 40, probably his shade will be much darker than earlier because of the various changes that are occurring into the tooth. The Vita Shade Guide is rearranged according to the brightness of the tooth that we have. The lightest being B1 to C4. So somewhere in between is the natural shade for that particular patient. I am going to tell you how to select that natural shade for the patient. That is more important. If the teeth have this natural shade, then why does dimming or why do the tooth discolor? They discolor because of the pigments that get impregnated in the structure of the tooth. And when these pigments, they form a larger molecule called as camphor, and it starts reflecting the light at a greater wavelength, and therefore your tooth starts appearing darker in shade. Since we are scientific people, we cannot start any lecture without telling about the definition. So definition was again given by Studevant, who said that lightening of the color of the tooth is because of application of the chemicals. However, I think in today's time, we should mention here that the change in color shade is without the use of any restorative material. Like we are not doing any restoration on the tooth. We are changing the color by doing bleaching. If you go back to the history, and this is so very interesting, that long back in Babylonian era also, there is mention of tooth whitening. And they have mentioned that something like as salt of akkad, which they have used to make the teeth brighter. So I think humans, since ages, are convinced that a brighter and a clearer smile is better. And the second interesting thing which I found is about Dr. Bill, who in 1960, he was an orthodontist, and what he did was that he used to give his, because earlier they were using for orthodontic purposes, they were pinching the bands on the teeth. So they used to cause a lot of gingival inflammation. So he used to give custom fitting trays to the patient with glyoxide in them. And when he found that when the patient came back after a week or so, he found that the gingival inflammation was less, but also the teeth were much brighter. So here the night guard bleaching philosophy came into being, and then it was Haywood and Heyman who first introduced the white and bright system in form of the night guard vital bleach, which is a very popular method of bleaching the tooth. So now we know that the teeth will discolor. And there is a definite process which occurs, a chemical process which occurs, and a chromophore is formed which will discolor the tooth. But we must know why it happens, because without knowing as to why the discoloration is happening, we will not be able to select the appropriate treatment for that particular patient. And then you will not be successful in giving the patient the right results. So coming to the etiology, we have these external stains, which are there on the tooth either because of accumulation of the chromogenic substance on the external surface, or because of the reaction these substances have with the sugars and the amino acids, or because the chromophore gets embedded in the tooth pellicle, which is naturally present on your tooth. For the extrinsic classification, we have three types. That is N1, they have said, is a direct dental stain. That is whatever tea, coffee, wine that you have, if it goes and attaches onto your tooth, then you will have a discolored smile. So these are direct stains. N2 are also direct stains, but they are because they adhere to the plaque that is there on your tooth structure. And the N3 are stains which are indirect stains. They are not the stains which, like many times we tell the patient taking chlorhexidine mouthwash. He comes back after a few days and tells you that his teeth are looking discolored and not a brownish color or a blackish stain is there. These are not direct stain. Chlorhexidine itself doesn't have any color, but it goes and attaches on the plaque. And I think chlorhexidine is known to increase a particular type of bacterial strain, which is black pigmented spheroids, and these discolored the tooth. So we have to know what exactly is the cause of the discoloration. Apart from the stains, we have intrinsic stains also, and in this we have some local causes of intrinsic stains which are easy to treat in some cases but not in all. Like in aging, if the tooth is discolored because of aging, we may not be able to help much. Root resorption, yes, we can help. Endodontic materials, sometimes we can help, like MTA was causing a lot of discoloration of teeth. And coronal restorations also, like silver amalgam used to discolor the tooth, the crown portion of the tooth, so we can replace it with composites. And pulp also is known to cause, like the degenerated or necrosed pulp will cause the discoloration of the tooth, even hemorrhage. It is said that when you're doing a root canal of a vital tooth, you have to be very particular of using a good irrigant. Otherwise, because of the pulpal hemorrhage, the tooth crown may discolor. And if you leave behind any remnants on the pulp, that will also cause the intrinsic stains on the tooth. Intrinsic stains are also systemic, very difficult to treat in almost all the cases. We have metabolic, genetic discoloration or drug-related discoloration. Metabolic causes, which is like fluorosis, is also considered as a metabolic stain. So in fluorosis, the initial stages of fluorosis, we can help the patient to have a smile which will improve with bleaching. But in a later stages of fluorosis, we cannot help the patient much. In genetic, where there are congenital deformities, very difficult to do bleaching. You should always try not to intervene in such cases and try to direct the patients towards more about coronal restorations. Then we have drug-related. Tetracycline was in our days, it was thought to be a very major molecule which was causing the discoloration. But going back now, I think tetracycline is not that much used in today's times. So I think future generations are unlikely to see tetracycline stains in patients. As well as fluoride, use of fluoride. This fluoride here will definitely, if it is mild fluoride, we will be able to help the patient. So this chromophore is of two types. You have metal containing compounds as chromophore, or you have large organic compounds. So in case if they are metal containing compounds, they are very, very difficult to bleach. So in these cases, before, like if you have diagnosed, if you knew the etiology properly, if you've taken the history properly, and if you know that this is a metallic compound discoloration, you should try to gently direct the patient towards better aesthetic options like veneers or bondings or use of crowns. When the cause of the etiology is large organic compounds, here we can break the conjugated double bonds of these organic compounds and break them into small molecules which are lighter in color. So these are very easy to bleach. That is why it is very important at the outset only to diagnose why there is stain on the patient's teeth. Coming to the phases of bleaching. The first phase is the diffusion of the chemical which you are using. There are various chemicals, but whichever chemical you are using, it diffuses into the enamel and it dilutes the chromophore. That means the dissolution of the chromophore itself or dilution of the chromophore itself will reduce the intensity of the pigment and the tooth will start appearing lighter. This diffusion of the chemical inside the enamel stays there for almost 2 weeks. So for 2 weeks, be certain that your patient's teeth are going to look white. The second phase is that this chemical will start interacting with the chromophore and will break it down into small molecules. And these molecules reflect the light in a different way. And therefore, your tooth appears white. So if you have reached the second stage, then your bleaching is going to last longer because you have achieved the breaking down of the molecules. And the third stage is that because of the action of these chemicals on the tooth surface, the enamel surface itself gets altered. So roughness of this altered surface will start reflecting light in a different manner. And because of this also, the tooth starts looking lighter in shade. So it is a 3-step procedure. Like we are applying bleach doesn't mean only that bleach is breaking the chromophore and it is solving the problem. No, all the 3 stages are important. So coming to bleaching agents, hydrogen peroxide and carbamide peroxide are the mainstay. There are many molecules which came, but there are no long-term acceptability and relative efficacy of these molecules, and so they are not routinely used. Hydrogen peroxide is there in almost every of the cases. In fact, in some of the products where the manufacturer were claiming that there was no hydrogen peroxide had to be taken off the shelf because of FDA reporting that they have, like they will not put hydrogen peroxide directly, but they will put with another molecule and claim that there is no hydrogen peroxide used. So currently all these molecules that we are using peroxide compounds. Even carbamide peroxide has hydrogen peroxide in it. So coming to this most interesting solution, that is hydrogen peroxide, we should know that this hydrogen peroxide is a part of your body. Though it is present in your body, I'll show you that though it's a colorless, odorless solution, and we are using about 3 to 35% of it, it is a normal intermediate metabolite in the human body. Almost 6.48 grams is made in the liver every single day. Still, there are many confusion about hydrogen peroxide. So many studies are there if you search the literature about the side effect of hydrogen peroxide. Some are concerned about the local side effects and some are concerned about the systemic side effect. The local side effect, its action on the pulp, gingiva, and enamel are within our control. We can reduce the percentage of sodium of hydrogen peroxide and then solve our problems. Or we can do isolation of the tooth and try to prevent injury to the gingiva. But the systemic causes are the one which is causing a lot of controversy. That is because the hydroxyl ion that is released by the hydrogen peroxide has been identified in various stages of carcinogenesis. When the word carcinogenesis comes, everyone gets scared. No one wants to deal with any molecule which is related to, which has any carcinogenic potential in it. And the second thing is that hydrogen peroxide has oxidative reactions with protein and lipids. And these oxidative reactions are responsible for the age changes in a patient as well as degenerative disorders. So it is the systemic causes that are causing so much of controversy about hydrogen peroxide. And a lot of scientific deliberation keeps happening, and there are legal challenges on this, but it is still rampantly used. So the second molecule they came up with was carbamide peroxide, in which urea peroxide was added, but it did also contain hydrogen peroxide in it. Finally, the breakdown products were better, like you had urea, ammonia, and carbon dioxide, which they said have no carcinogenic potential. So this started becoming popular, has started rather. But the American Academy of Cosmetic Dentistry categorized the system of all the bleaching solutions that we are using into 3 types. They said that the vital tooth bleaching can be in office or power bleach, at home, or that is night guard bleach that we use, or do it yourself, or over the counter products. I just want to tell you briefly about all these products, because these products have been rampantly used not only by the dental specialist, but by the you can say there are salons. It is available in the malls now. It is available even on the high profile cruises now. So these are accessible to everyone now. And it does affect us because it affects the patient's teeth, and also sometimes it affects our treatment protocol also. I'll explain it to you in the later slides. So let me start with the do-it-yourself products. If you go into Amazon and just click tooth whitening products, you will get, I think, at least 50 to 60 products telling you that this is good, this is good, this is better than that. And it's really remarkable as to the amount that is being pumped by the industry into trying to tell people that it is the whiter teeth which are most important in life. It's really sad at times, but it is true that this is happening. So we should know what are these. So the first was the toothpaste. So we all have this toothpaste, teeth brightening toothpastes that are available. Only thing they did was that they increased the abrasive content of the toothpaste, and that resulted in removal of the superficial pigments that are there on the tooth, and that caused the teeth to be lighter by 1 or 2 shades. Because there was a worry about hydrogen peroxide, they came up with something called as activated charcoal. And when I saw this, I really had a shock, and I just thought about our grannies and great grannies, and I'm sure they had the last laugh, because they were the people who were picking up this charcoal powder and brushing their teeth every day. And we stopped them and started asking them to use toothpaste because they were less abrasive. So the same thing is for this activated charcoal. Maybe the particle size is smaller, but what it is doing is it is abrading the tooth. So continuous use of such substances may harm the teeth of the patient. So any of your patient telling you about this, you should ask them to stop it. Then came the strips, because we wanted something better, easier to be done, and which can be done on the go or in the office also. So we got 3 types of strips available according to the concentration of hydrogen peroxide that is there. And they say that using these strips for 14 days, once a daily, only for 30 minutes, can help you. Their strips is like small, you can just carry it in your purse. There is no dispensing needed. It is single use. In the office also, you can use after, like if you have a party somewhere, you can use it in the office, and just after you finish 30 minutes, you can just dispose it off. So they made it so easy. But these strips were causing gingival irritation. Not every patient is aware about where to place the strip. Some don't know the demarcation between the teeth and the gum. So if it is more towards the gum, it was causing irritation of the gingiva. And if the teeth of the patients were malaligned, then it was not possible to use these strips. So they came out with a better solution. They came out with something called as peroxide gel, which they said has a brush in it. You just take it just like your nail paint. You just take that small bottle to the office, apply it on your gums, leave it there for 20 to 30 minutes. You can do it twice daily also. And you could apply it on the malaligned teeth. Also, since it was used by single person, there was no microbial contamination. And there was no peroxide inactivation, which was described, which was seen in the strips actually. So this was thought to be a better solution. In fact, when I was searching on Amazon, I found that a person, they have this gel with a LED, it's a tray with a LED bulb in it, which you can plug in onto your mobile, like your mobile socket, and charge it and place it in the mouth, and the patient would have brighter teeth. So we are just trying to play to the gallery and want that the patient should start using these things and have brighter teeth. But it doesn't work like that. Rinses was even more easier. Like you just take the solution in your mouth, rinse, and your teeth will become whiter. In fact, you check on Amazons and all these sites and you will see how many rinses are there. You have tobacco, you can rinse this with this rinse. If you're taking smoking and all these things, then you can use this kind of rinse. Even tea, coffee rinse are there. Post tea, coffee rinse with this, you will not get stains. So all these market gimmicks are being there. So yes, so this is important. So what are the pros and cons of these home bleach products? The first thing was that they are self-administered, they are low cost and active patient compliance. Anywhere you can do. Even before the Viva, the student can use it and come and try to impress the examiner with a bright smile. So it was that easy. But on the negative side is that the results are not ideal, and overzealous use could lead to damage to the tooth. And it could lighten the teeth only by 1 to 2 shades even after 4 to 6 weeks. So the overall data, there is nothing adverse reported by use of these over-the-counter products. That is why they are so rampantly being used. I think hundreds, if not less, products that are available where you can keep. But all this is because the adverse effects are not being reported by the patients. Firstly, maybe they don't know that it's an adverse effect, like they cannot identify erosion of the tooth, or they cannot see that the surface of the tooth has become rough. So that is one thing, and they are not aware of the procedure of how to report these adverse effects to the US Food and Drug Administration. They have this MedWatch system. I am not aware of what system we use in India, but abroad they have this system where you can directly report to FDA that these are the drawbacks. So there is a definite concern of overusing and abusing of the over-the-counter products, and research efforts are encouraged to define the risk of these products. So any one of you who is interested could take over this kind of research and probably help the community, the dental community. As clinicians, does it affect us? Here is the point. That is why I told you about all these things. Yes, it affects us. It affects us because the patient cannot diagnose his discoloration. He will start using all these products, over-the-counter products, and when it is really bad, he will come to you. And if you are unable to help him, then he will put the blame on you. So the worst part of these over-the-counter product is they are being used without diagnosing what is the reason of the discoloration. The second is that if the patient is using these products at home and you happen to place a composite restoration on these patients, they are likely to debond. So many composite restorations, so many workshops on smile designing are going on, and we are doing it, I think, every day in every practices. And equal number of patients are using over-the-counter bleaching products. We all know, I will tell you in details later, that the presence of hydrogen peroxide on the tooth surface or on the subsurface area of the tooth, it can cause weakening of the bond between the adhesive and the composite. The bond is not good and these restoration will not stay in place. So it is important while speaking to the patient, it is important to ask him. You have to give them leading questions. Are you using this, any of the over-the-counter products? Are you, is there anything else you have done to whiten your teeth? That way you could give leading questions and ask the patient. The second is about the orthodontist. And this has happened to us that the bonded brackets do not stay on the surface of these patients. So many times the patient comes back with the loosening of the bonded brackets. Many a times it is not, the cause is not bleaching. But I had this one patient, I think we tried all the systems. We changed the brackets, new brackets we changed actually thrice. We did it over almost 6 months. After every 8 days, 10 days, the patient used to come back with rebonded brackets. Unfortunately, I wasn't aware of this particular relationship between use of over-the-counter products and the bonded brackets becoming loose. So I could not probably handle the patient properly and we lost the patient. I agree to it that we lost the patient, but to you all, I would want to say that if this happens to you, it would be prudent enough to ask the patient once that is he using any of these products, and probably try to look into this also. I do not say that this is the only cause of debonding of brackets, but this could be one of the causes. So American Dental Association has given very clear advice that they do not advise the general public to use over-the-counter product without consultation of their dentist. And it is very important. And I think the similar thing should be done by our associations as well. After this came the tray-based tooth whiteners, in which we had do-it-yourself, again do-it-yourself products. So they were using 3.5% of carbamide peroxide, and stock trays were there which were very poorly adapted, and the patient had to wear them for 1.5 hours at home, sometimes more. So what was happening is that there was injury to the patient's gums and the solution was leaking into the patient's mouth and the patient was uncomfortable. Then came the dentist monitored. Once we had increased the percentage of hydrogen peroxide here, or carbamide peroxide, sorry, and we made professionally fitted trays which were fitting better, and we checked onto the gingival margin and we tried to give the best to the patients. So these are considered as a gold standard. Even today, if you have to compare any bleaching technique, we considered this as a most gold standard technique, and it is very safe and cost effective. The next is the in-office bleach or the 1 hour bleach. This one bleach is getting very, very popular because the patient don't have time. The clinician wants that his chair should be free for the next patient to come in. So 1 hour is something which is very interesting to all of us. So this in-office bleach uses very high percentage of sodium hydrogen peroxide. And the advantage is that once you put it into the patient's mouth and the patient is in your clinic, you have total control over the patient. And the patient will not make any, the hydrogen peroxide will be not injure the patient's gingiva. Here, the most important thing was isolation of the teeth, which is mandatory. I think nowadays we should remove this point because we are using isolation for every single procedure and it's become mandatory in dentistry. But the most important thing was the dehydration of the teeth. This dehydration of the teeth is very important. I'll tell you later why, but this has caused a lot of problems. So these are the many methods by which you can do in-office technique: power bleach, laser bleach, assisted bleaching, chairside bleaching. These are all the synonyms that are used, and different materials are available again for us to use. The advantage is that it allows the professional to keep all the cycles of the process under his control completely. In office bleach technique, in short, I would like to tell you, starts with isolation, then application of the bleaching agent which you have chosen, and activation. So these three processes are very important in this. And this is why in-office treatment can result in significant whitening only after one sitting of the patient in the clinic. We might need about 3 passes in one sitting. Each pass could be about 3 to 20 minutes. Even if you take 15 minutes, it is within 45 minutes that a patient will have a good bright smile. So the activation was happening with the use of all these type of lights. You had halogen, plasma, laser, xenon, metal halide, all these lights were available. And the most appropriate source of light was that which will avoid any harmful effect on the tooth structure. Before I tell you about light, this one slide I like very much because this is one slide which cleared my confusion also. In the region of electromagnetic spectrum, there is one small spectrum between 400 to 1100 nm, where it is safe to use this wavelength of light in a human body. So this is called as the biologic window. And the light which is in between these two wavelengths is safe on a human body. And that is what we have explored, and that is how we have these lasers and LEDs which are being used rampantly in the clinics. Coming to the lasers, it was the argon laser which is introduced, and its wavelength was around 488, and it caused photochemical activation of the concentrated gel. But there was no rise in temperature, so it was useful. There was no pulpal damage. Diode laser came in first, but they were unsuccessful because they did cause a lot of heat production. The European dentists have come up with use of KTP lasers, where the wavelength is around 532 and it emits green light. This green light directly causes oxidation of the tetracycline molecule and makes it colorless. If it is absorbed by the rhodamine dye, it causes photothermal as well as photochemical reactions, leading to release of the oxygen radical. And this oxygen radical is responsible for bleaching. LEDs in dental bleaching. LEDs came to dentistry long back. We all use this type of LED that is used for the composite photopolymerization. The wavelength of this blue LED matches with that of the argon lasers. And so they are useful as a source of light activation of the bleach with minimum of heat generation. So this green light was very, very helpful for us, and they started to use this in dentistry. But here also we required a gel, and it was this gel which was causing all the problem. We found that it is the gel which generates the roughness on the surface of the tooth. And we also came to the conclusion that if sunlight could discolor or fade our clothes and plastics, why can't we use a similar light which can discolor the tooth pigments, colored pigments? So with these two philosophies, they combined and they came out with this violet LEDs, which are in a wavelength of 405 to 410. And these violet LEDs are capable of performing tooth whitening without the use of bleaching gel. The violet light itself enters the tooth, interacts with the pigment and breaks them into smaller colorless parts, and the tooth starts looking whiter. So this is the newest thing that is in dentistry now, and it is based on the biophonetics, photonics, which is about the interaction of a molecule with the light energy, where either a chemical reaction is started or the absorption of light itself will break the molecule and make it disarranged and lead to colorless pigment formation. But with this light, there were safety concerns, and though it is known that visible LEDs in the wavelength of 405 to 410 do not present any problem with the patient, or there is no molecular changes occurring in the tissue, but you have to take care, and you should not aim these directly at the patient's eye or the patient directly, and it is better to use glasses when you are using this kind of light system. If you go back to the literature, there are hundreds of papers. I tell you, I think bleaching is one of the most researched subject in our specialty. If you go back there, these are only few of the studies I have put where they have said that use of light is good and you should use light so that it improves the bleaching potential of the gel. Equal or maybe more number of studies are there which are saying that no, use of light does not help at all, and you should not use light because it is harming the surface of the enamel. So then what you should do? If you just take the whole what has come in from them, they say that whitening with or without light is not going to change anything. They also say that multiple visit will be needed whether you use light or you don't use light. And even if you are using light, like patient thought that you can use light and they don't have to go back home and do anything else. But no, to maintain the whiteness of the tooth, the patient has to use, at least for 1 week, they have to use tray whitening systems. And sensitivity is definitely reported after use of lights. So why are we using lights? The reason we use light is because patient expects us to see light. It is the patient who wants to see light. It is the patient who feels that if you have not used the light, you have not given a good treatment. There are some misconceptions in the patient. Even if you do the best treatment and not use a light, the patient is not going to get impressed. So it is more of a psychological benefit that we are using light. And even ADA says that light enhanced bleaching is important only for patient satisfaction and marketing. So if you do not have, like we had the Zoom material is so expensive. It was so expensive to use. So now we have come up with better ways to activate the gel, and the one of it is like ultrasonic activated bleaching or comprehensive bleaching techniques and dual activation techniques. So all this come only for the simple reason that we want that the bleaching should happen faster and the patient should be satisfied and we are able to give a good treatment. So in dual activation, what they did is they added both the things, light activated as well as chemical activated. For this, the treatment time reduced down drastically, almost it came down to 7 to 9 minutes. And you could also see the gel changing the color. And so when it became chalky white, you were sure that your bleaching is over and you can do a next pass of bleaching, or if you're satisfied with the color, you can stop there. Then came the ultrasonic technology, which said that addition of ultrasonic energy to the bleaching gel will enhance its penetration into the enamel and make it more better. And there will be more production of the free radicals. Then came the comprehensive bleaching technique, compressive bleaching technique. I'm so sorry, compressive bleaching technique. So in this, what they said is that if you force the hydrogen peroxide inside the surface of the tooth, then what happens is that the hydrogen peroxide will go deeper and will destroy the color pigment inside, and the teeth will appear whiter. But this is very, very controversial. They tried to seal the custom-made tray with light cure acrylic resin and put the gel there and try to force the gel inside onto the tooth. But there are very few studies which support this, and the hypothesis that the nascent oxygen might enter the pores through such a pressure is also debatable. Now comes one treatment which is very close to my heart. We have done so many patients on this. We have a published paper also on this, and I think I will be showing you some cases in the end. So many of these cases have given us very remarkable treatment. The philosophy of this is very simple. They say that you do enamel macroabrasion with a 12-fluted carbide burr, or you do enamel microabrasion with 12% sodium hydrochloride, and enamel glaze will form onto the tooth. This will reflect and refract the light in different way. So there is this abrasion effect, and we have personally about documented 25 to 30 cases. I have presented this paper in Cochin National Conference of IES and IACD long back, and since then we have collected so many cases, and we have got very good response in almost all the patients. I would like to tell you here that we are in the area of which is considered as the fluorosis belt of India. And we have many patients coming around from the nearby areas who have this fluorosis stain on the teeth. So in all these stains, we have found very good results in almost all the patients. The advantage of this particular technique is that it is very cost effective, doesn't require much of the time. It is minimally invasive, and definitely there is a lot of psychological improvement in the patient. This is the psychological analysis of the patient. Probably our first patient we did. You can see the change in her smile. She's almost, this is 12, 15 years back. She's a married woman today, and daughter of one of our staff in the college, non-teaching staff of the college. So we are following this case, and we are really pleased with all the response we got in this particular case. So I would like to tell you here that it is not necessary that you go towards all the big things or all the new expensive type of treatment that is there in the in your clinics. You can use small, simple treatment and get good results. So this treatment, which has faded from our list of treatment modalities, I feel should be revisited and revived, especially for colleges or like colleges which are in the rural areas where there is no access to for the patients, or they don't have the economic ability to spend so much on the bleaching techniques. They should be given a chance, and this treatment should be tried because it is simple, it is inexpensive, and it has given very good results. So here was the, now your setup has all the materials that are there. You are aware of all the materials that are there. Now comes the most important thing, that is about patient selection. See, for all the other treatment, the patient is coming to you, he's coming for some pain or some rehabilitation, some swelling. But here, the patient is coming to you only for a treatment which is not essential. It is, the patient wants something only to enhance his smile. If by your neglect, you are unable to give that smile to the patient is going to feel unhappy. At the same time, he's unlikely to come back to you. So the essence of any practice is that the patient comes back to you. So like I am practicing that this month is 25 years of my practice. So I have done many patients on bleaching. And I tell you, this is one of the most satisfying thing. I have these patients coming back today to me with their children and sometimes grandchildren, because in some communities, the marriages happen very fast. And like I have given them bright smiles at the time of their wedding. So if they are in the city or if they want any treatment, they do come back and they do remember it. So that type of satisfaction, I think only aesthetic dentistry gives. The patient is never going to forget you. So here is the time where you have to invest time in trying to talk to the patient, tell him what you can do for him, what he should expect. So this becomes important. How will you select the patient? First, you have to ask about the patient's lifestyle. If the patient is going to go back towards his old lifestyle of having gutkhas or tobaccos and all those things and not going to change his lifestyle, then doing any type of the treatment is not going to help you. You have to diagnose the type of discoloration. Before you start the treatment, you have to give the patient an idea of what discoloration this is and how much you can change the color. If you are not going to change any color, why should the patient keep coming to you? As I said earlier, many patients come to you before their marriages or before the important events of their life. So they already don't have time. And they are investing time in you only because you have given them the confidence that you can give them a better and a brighter smile. So you have to live up to your promise. Always check the baseline shade of the teeth. If the baseline shade of the tooth is darker, no matter what you do, you cannot change the color for the patient. For that, you have other treatments. You should you should tell the patient about those treatments rather than wanting them to do any other, wanting them to go for bleaching. Also, the time available for bleaching. We have some treatments where we are asking the patient to come every week, thrice, once a month, twice a month. But is the patient able to come? Or what is the requirement of this particular patient? That you have to first judge before you select the system which you want to use in that particular patient. If this particular patient also needs a restorative treatment, then you have to plan your bleaching before at least 1 week before. Before that, if later on, if you do, like if I do bleaching today and I do a composite restoration tomorrow, I am in a mess. We all of us have these patients coming from for their vacation from US, UK or wherever, and they want that all the treatment should happen in 1 week's time. So you could gently tell the patient that bleaching and this restoration may not be possible. Right now, restorations are important. Go ahead with the restoration. We can think about the bleaching in the next visit. Or you can give them at-home products also. And you have to select teeth which don't have decay or periapical lesions and sensitivity. Having a bright, happy smile which is painful or which is making food get impacted in your teeth is no winning game. It is sad actually. Our first aim is to restore and rehabilitate the oral cavity and then go in for enhancement or the aesthetic treatment. And always please remember that bleaching is totally contraindicated in pregnant women, as the effect of bleaching materials on fetus is yet to be investigated. Don't be the one who do bleaching on a pregnant women. Nowadays, we see so many photo shoot of pregnant women happening. It's very nice to see actually. The younger generation is documenting all parts of their life. But at that important time in their life, they are also coming back to us because in their pictures, they want to look beautiful. But you can do any other treatment. But if they are asking for bleaching, I think you should gently dissuade them from doing any such thing. Then if you see the stains on the teeth, these are the 4 things which you should remember. If you see the teeth are yellow and with no developmental pathologies, you are definitely going to get a good result. Second is if the patient is younger. these two times, your results are definitely going to be good. Whether it is a male or a female, it doesn't make any difference. You can, in both the we find equal responses. But tobacco and dark brown stains are very, very difficult to treat. Tobacco stains, we may be able to lighten a bit, but the patient mostly goes back to his habit, and therefore this treatment is not very successful. Now comes the most important part. We have all been talking about the bleaching, isn't it? But do we know that there is an inherent lightness potential of each tooth? Greater than that, greater than this final level of lightness, which is the end point of bleaching, you cannot change the color. This color will remain no matter how much bleaching you do later on. So you have to analyze what is that inherent potential of this particular patient and then decide upon the bleaching treatment. So if within 6 weeks you do not get the change in color, be sure that you have reached the inherent lightness potential in that particular patient, and you are not going to find any change in the result after this. Also, please remember, when you talk to the patient, that if you are using in-office bleach, you can change the shade up to 7 to 8 shades. But even a shade change of 2 to 3 could also make a subtle change, and it will be perceptible as brightness of smile. So the patient wants a very bright smile, like you can do a 7 to 8 shade, but even if you achieve 2 to 3 degree of lightness in that particular patient, that subtle change is also going to look good on the patient. You must tell the patient that if you're not happy, you can go back for additional whitening. See, patients comes to you, you show him his teeth, and he will say, okay, I want one more shade lighter, one more shade lighter. You will keep doing his bleaching, but this is not the right thing to do. You have to tell the patient, you go back, wait for some time. If you're not satisfied, I can do additional whitening for you. But always remember this very important point is that if you over whiten the teeth, there is no treatment, there is no way where you can get back the teeth to a shade which the patient wants. The patient just has to wait, and at times it is more than 3 months. So please do not fall for what the patient wants. It is better that you analyze what is the best thing you can do for the patient. Also, there are many studies, and many people always tell the patient that that before doing bleaching, why don't you have your oral prophylaxis done and all. So literature doesn't support any of these findings, and they say it doesn't make any difference whether you undergo oral prophylaxis before doing bleaching. So it is totally up to you. But personally, if you ask me, I would like to work in a clean mouth, and I think presence of calculus and all will not give you the required bleaching effect you want. So what will be the final factors you will consider before you start your bleaching? First, you know the shade, you have decided what the existing stain is, and you know you want to do bleaching for this. You have also seen that the patient do not have any restoration. Presence of restoration while you are doing bleaching will not change the color of the restoration, whether composites or the older patient silver amalgams or the ceramics. Okay, it will harm maybe the structure of composite, but it will not change the color of composites. It will make the silver amalgam more black, and it will make your temporary restorations, if any, more orange. And one of the most important thing is the color of the sclera. The next slide, I'll tell you why. It is the color of the sclera that has a direct correlation between the eye and the tooth. So when you are selecting the shade of how white the teeth should be, you should look into the patient's eyes and try to match the shade which is closer to the white of the patient's eye. If you do not do this, this is what you get. I'm sure all of you have seen the serial, one of my favorite characters also, Ross. And if you want to see, you can see this particular episode on tooth whitening in Friends, that very popular serial. And you see the color of his teeth and see the color of his sclera. How unnatural that smile looks. And here also in this particular episode, he keeps saying that I have to wait now till I get back to my normal color. The dentist says that he cannot help in any way. So this is how distinct it is. Also, one small hint is that if the sclera, if your teeth are lighter than the sclera of your eyes, that patient is not going to respond for bleach. So looking into the eyes is not only for romantic purposes, looking into the eyes is also for diagnostic purposes. So please use this particular way of diagnosing the change in color. Before you change the color of the teeth, it is important that you document what is the shade of the teeth before treatment. For that, we have shade guides. But the problem with this is that it differs from person to person. And this tooth color, how to discriminate color is according to the individual. Even the fatigue of the eye or the makeup or the room decor might affect the shade you have chosen. But of course, it's a learning cycle, and you can learn how to check the shade of the teeth. Also, there are specialized equipments like the colorimeter, which can measure the color, and it will give you a direct color, what should be the color change. But I am not aware of any practices which has this. But yes, many of them are now using this non-contact camera-based digital imaging and analysis system, which takes pictures of the patients pre-operatively, analyzes it in a software and gives you the shade. Why shade documentation is important? It is because the patient, if there is a change of 2 to 3 shade, the patient doesn't remember that his shade has changed from by 2 or 3 shades. He feels that his teeth are just more clean. That is why they are looking brighter. But if you have documented the shade, pre-op shade of the patient, you can tell the patient the difference that you have achieved by your treatment. Also, a very good practice by many of the practitioners, including me, and I think I learned this in one of the conferences I went to, where they said that when you are wanting to bleach in a patient, a full mouth bleach, then first bleach the upper arch. When you bleach the upper arch or any of the arch, some say lower arch, some say upper arch, but bleach only one arch. When the patient sees the difference in between the 2 arches, then he is motivated to undergo change of the color of the other arch also. And there is a documented proof that your treatment has changed or lightened the teeth. So this was about the selection of the patient and what you're going to do and what were your materials. Now coming to some concerns in bleaching. One of the main concerns is about the soft tissue burns. So these are very common when you are using high powerful office bleach. And this results in a patient having these white patches on his teeth. But the one good thing about this is that they are easily reversible. If you apply an antiseptic ointment, you can reverse it. Important would be to protect the soft tissue. You should use isolation systems to protect the teeth and not burn the tissue, especially if the patient is coming to you just before her marriage or some important event in her life, and then you end up burning her gingiva. I'm sure she's going to curse you through your life. Apart from this, there might be injury to the gingiva because of the ill-fitting trays that are made. they might harm the gingiva and the patient might have small ulcerations there, which turned out to be painful. The second is about tooth sensitivity. It's a very, very commonly observed problem with bleaching. And especially it is seen if the patient is having restoration, which are defective restorations. Good restorations may not lead to sensitivity. They are because the solutions tend to trickle down into the pulp and it does cause a lot of sensitivity. And this sensitivity is not related to the patient's age or his sex, or even they say defective restoration, but definitely research has said that there are more chances of sensitivity if there are defective or no restorations rather. Incidence and severity of sensitivity may also depend on the quality of the bleaching material that you are using, the techniques, and the individual's own response to bleaching. And you know what happens is sometimes you're using, for example, power bleach, you're using very high powerful bleaches. So they are going to, in different individual, every individual will have a different reaction to those particular solutions. And the patient may end up having sensitivity. Imagine going to a clinic where you have no problems and coming back and getting to know that you can't have ice creams or you can't even have clean water. So the patient is going to blame you. Here also it is very important. See how important it is to interact with the patient. You need to tell the patient that maybe there can be sensitivity. So it is in his mind, he is already aware of the fact that there can be sensitivity. And sometimes the patient will just mistake the gingival irritation as sensitivity and complain about it. So you have to diagnose it properly. Does bleaching solution cause changes in the surface morphology? Yes, because there is porosity of the enamel structure, and they have seen that there is definite demineralization and degradation of the organic matrix. So over-the-counter products, they say, could also cause this kind of surface deterioration of the enamel, and therefore we do not actually tell the patient to use these products indiscriminately. Here I come on effect on bond strength of dental composite. Pre-operatively, we have enough documentary evidence that bleaching, pre-op bleaching has caused a lot of weakness in the bond strength, and therefore this is more because of alteration of the protein and the mineral content of the superficial layer, and also the tags, the adhesive tags which are formed are weaker. Post-operative also, they have seen that composite restorations which were there and then bleaching was done, they have become loose because of the breaking down of the bonds. Is it possible to improve the bond after bleaching? Yes, it is possible. They have said that you can use ascorbate hydrogel, which if applied on the tooth, it will immediately, like you can immediately do a composite restoration. Second is that you can, easiest method is delay bonding procedure for at least 1 week. Or one very interesting herbal product they have come up with is the grape seed extract, and they claim that it improves the bonding significantly. Immediately if you want to place the composite restoration. And if you still happen to do, and if you want to do, then the best technique for doing adhesion here is about etch and rinse adhesives. They have found to be more effective. Effect on restorations, they do chemically react. I have spoken about this. There is surface softening and color change in composite restoration. Coming to systemic effects of these bleaching agents, not many have been reported, but some patients have reported about gastrointestinal mucosal irritations, burning of palate and throat, and minor stomach upsets also. So these are more related to home bleaching agent if the patient is abusing its use. But overall, we conclude that bleaching is not harmful to the patients. Effect on the pulp is one thing which is very, very important. They say that because the hydrogen peroxide penetrates into the pulp, there may be mild or transient hypersensitivity. That is one thing, but it might irreversibly change the morphology of the odontoblast, and later on the pulp might just degenerate. There are cases reported of coagulative necrosis occurring in the lower incisors because of bleaching that has been taken place. Another important is dehydration of the tooth. This is occurring because, as we said, that the surface is porous. The most characteristic thing we have always felt is that if you apply something on the tooth, it is porous. The whatever you have applied should go inside, isn't it? But only that thing doesn't happen. If you are applying some irritant on the tooth surface, the fluid from the dentinal tubules and the pulp might start draining outside. It might start coming towards the biosmosis, might start coming towards the surface. And this could be the reason why sometimes your bleaching solutions are not effective. And if you are applying light to it, it is further going to aggravate this movement of the fluid. This can, if you have applied light, then this light will convert it into heat energy and further will cause the pulp to degenerate or cause inflammation in the pulp. And this could also be the reason why there is sensitivity which is occurring. Also, please remember that dehydrated tooth after 7 days will become rehydrated, and the bleaching effect which you saw earlier will relapse. So this rebound effect doesn't means that your bleaching was not done properly. And this is very light accelerated tooth whitening protocols. Now, if the bleaching is there, then how do you maintain? You have to tell the patient how he will maintain his bleaching, the teeth which are white now and nice and sparkling. You will have to tell them that you should use whitening toothpaste, not regularly, but at least 1 week in a month. If you are using beverages which have staining potential, then you should use a straw. For women, a very important hint that if you want your teeth to look lighter and brighter, then use bright shades of lipstick like blue or pink, and it will definitely make a difference. I had seen a very good picture of this, but I missed on that. And you have to tell the patient that he needs touch up at least after 6 months, 12 months, or 24 months to maintain this smile. Bleaching relapses have been reported, though we say that bleaching is effective and safe. Relapse of 41% at 1 year with tray bleaching is reported, and about 26% at 18 months have been documented and reported. This is another very important thing to share with you. There are cases in the literature where they have reported about people with psychological problems, maybe, who are bleachorexic or bleacho-alcoholic. The reason why they call them like this is because these patients keep on using over-the-counter products, office whitening products, just to keep on bleaching, wanting to make their teeth more brighter. So this extreme obsession not only causes severe surface erosion and cervical erosion. I had been to one of the conferences long back in 1997, Mumbai, Leela Mumbai. They had a conference on aesthetic, and there one case was presented where the patient's teeth had become not white, they had become translucent because of overuse of bleaching agent. So that I tried to search it on the net, but I couldn't find it. But this is one reported case, and I have seen this particular report when presented in that conference. I'm coming to the end of my presentations. To all the youngsters here, there is a lot of scope in bleaching if you want to pursue this as a research, because not the documentations are more about the adhesive strength, this and that, but how to measure the exact color change, what effect it will have on what effect the concentration and the dose and the outcomes are, what is a rebound issue, and how to overcome it. All these things need a very in-depth research for us to really document and come up with a good suggestions. So while the patient demand that tooth whitening is at all-time high, we know that, and dentists have more options for treatment, we also know this. It is important that the dentist should evaluate these options before giving the patient the treatment protocols, or before trying to encourage him towards taking bleaching as one of the treatment. So these are our case reports. All these case reports belong to the album of Endocons VSP MDC RC Nagpur. I'm thankful to all my PGs, the PG alumni who have contributed over the years on these. I'll just show you a few of them, and just to see the changes. The treatment, I am sure, as I said earlier, are there on the YouTube, so you can just watch them. This is the case 1, tray bleach, good results. Case 2, there is lightening. We then could go ahead with the composite veneer buildup of these patients. Very good result we got in this patient. As I told you earlier, we belong to the fluorosis belt of India. So we do get a lot many patients with this kind of discoloration on their teeth in our college OPD. This is Zoom bleach that we have done. Excellent result, but very expensive material to work with. Very, very expensive. In office, power bleach. Extremely nice results. In office again, in office bleach has always given very, very good results. You will always get good results when you are using power bleach. Comes micro abrasion. Not only it removes the surface roughness, it also gives a good glaze onto. You can see the glaze on the tooth very clearly on the patients, and the patients are so happy and satisfied. So we have a good number of cases on bleaching being done, and good reports that we have collected over a period of time. We intend to publish this someday, and I'm coming to the end of my talk. To conclude, when used following manufacturer's instructions, we have good whitening effectiveness and safety of all the bleaching agents. However, as with all the dental therapies, there are risks, and practice should be tailored to need of each individual patient based upon the type and extent of staining that you see in the patient. And it is very important that you inform the patient of the risk associated with tooth whitening. And if using tooth whitening agents at home, you instruct the patient about all the adverse occurrence that can happen. Supervision is the key to tooth whitening. You must assist your patients in all. So this is the last picture of my presentation. I want you to have a good look at the picture. And I'm sure many of you may not be able to identify what I'm trying to show. This is a tree and just next to my window. So here I am helping you. You can see a parrot sitting on this tree. So why I put this? Because I believe that the eyes don't see what the mind doesn't know. And this was a very important lesson which I got in my first lecture in my third year, when we went for the oral pathology lecture, and our professor, Dr. Vinay Hazare, said this, and it just stuck with me for always. So unless you know what is there. You will never be able to find or do the right amount of treatment. So this was my message to you today. So in any treatment, not even in bleaching, in any treatment, try to know the intricacies so that you can identify and give proper treatment. Those who know me know that I always end my talk, or I am all the time in search of something nice to be read and shared with. So today I tell you, and I want you to understand and be someone else's sunshine. Be the reason someone smiles today and always because of you. And that is why I said that if smile is power, you have the power to empower that smile with tooth whitening protocols that we have in our practices. So with this, I end my talk today. I sincerely acknowledge without my department colleagues, I do not, in fact, exist, I say, because they are a very integral part of me. And my PG students, past and today's, who have always supported me and in all my endeavors and been there to make this life so much more meaningful. Thank you to all of you.
Thank you so much, Pratima. It was a nice presentation. It was very good.
Thank you.
Yeah, I request Dr. Deepali to take over question answer session.
Thank you, Sunanda ma'am.
Yeah.
Yes, ma'am, Pratima ma'am, it was really a very elaborate and extensive lecture. You walked us through all the steps from case selection to the tips, clinical tips and tricks in bleaching. And it was really very interesting. You added even the scientific facts, and you talked about the KTP green light and the violet LDS, very interesting things which probably people can take up for research as well. I really thank you for giving us such an elaborate talk today. We do have some questions which I think so the audience have put up, and we will all be sharing that with you. I think so we have some time. So the first question that has been asked, should I, ma'am?
Yeah, you continue.
Yeah. Yeah, the first question that was asked is there any bleaching agent added to desensitizing paste? And I don't think there should be any this thing on it. Ma'am, please answer, and she will help us out with this clarification.
No.
Yes, ma'am. I think so. She was here.
What happened?
Pratima ma'am. I'm sorry, viewers. We'll be back with her in some time. She might have lost some connection.
Yes.
Please bear with us.
Let's call her.
Yes, I will.
Ma'am, I will call her.
Okay, okay, no problem. Till then, I think so, viewers, I will just help you with what Madam has taken up. She's given us a very, very broad overview and of vital bleaching today. And some of the interesting points that I have taken down, I can share with you. She did talk about how powered bleaching is probably a marketing gimmick, but definitely it gives very good immediate post-op results, and which you should take with care that, you know, after 7 days, probably you may lose some of the bleaching effect because of the dehydration of the teeth that occurs because of powered bleaching. It was very, very interesting and a very valid point. She talked about the chromophores, the type of chromophore influencing your treatment protocol, whether you should take up bleaching or whether you should not take up bleaching. I think so many of you are aware of this. If you have a metal chromophore, you are not going to go for bleaching. Probably veneering will help you better. And is Madam back? Sunanda ma'am, should I continue?
Yes, you just continued. She's joining within 2 minutes.
Okay, no problem. Or does Sunanda ma'am have anything to put in?
No problem. You just.
Yeah. And she really very well touched upon the do-it-yourself products. And she gave us a very nice example of her patient, orthodontic patient losing the orthodontic bands being debonded because of this problem. So I think so it's a very valid point that she made, that we need to see to it, ask our patients if they're using any of the do-it-yourself over-the-counter products in bleaching, which can, affect our treatment protocols, not only in orthodontics, but also in restorative dentistry. And I think so another interesting fact that she brought about is people talking about the systemic effects of hydrogen peroxide, and how hydrogen peroxide itself is a metabolite which is formed because of so many biochemical reactions going on in our body. That was really nice. And another thing that really impressed me was, I'm sure all of you are following it, but nobody has put it on board, the color of sclera, how the color of the sclera will influence what, till where you whiten your teeth. And the example of the character Ross that she gave from Friends, which will actually help you to educate even your patients that too much of white teeth is probably not going to enhance your beauty, isn't it? So that was really very nice. And the other point that I think so was the highlight of this talk was the 6-week window period, which she talked about on bleaching. So that really is important. Beyond that, probably you're not going to make any more headway into brightening, and you have to switch on to other methods. And friends, I think so you all know that many clinicians use office bleaching along with home bleaching protocols to enhance bleaching. Yes, Sunanda ma'am.
Thank you so much, Dr. Deepali. You had given us a bonus on this lecture.
No,
you had added.
There is no bonus. Actually, Pratima ma'am has all talked about it. I just probably am, summarizing it. Some take-home messages for the audience.
That will be remembered. Perhaps actually. So Pratima ma'am, she's joining.
She's here.
Yeah, I am so sorry. I am so sorry.
No. It's okay.
Yeah, all our networks have suddenly failed.
It's okay. Miss, are you ready to take up the question answer session?
Yes,
or we will just because whatever you spoke, Deepali has concluded it very nicely. She has given the take home.
Yeah. Thank you so much.
And she has done your job actually. Maximum job she has done.
We were just trying to see that the audience knows that you have covered such a wide range of issues which pertain to tooth whitening.
Thank you so much.
There are a few questions. The first question was, is there any bleaching agent in desensitizing taste?
I think, Pratima, if there is any network issue, I think we will send you the questions by WhatsApp or by mail, and you can clarify that. Not a problem.
Definitely.
Because I think there is she is finding some difficulty in taking up the.
She's your back, ma'am.
Yeah, we all are having difficulty. Actually, all of my department is here, but none of we are working right now. So
it's fine. We will send you the mail.
I lost you again.
we will send you the mail or WhatsApp questions. You can just clarify them.
I'm so
later.
sorry.
No, it's okay. And I just want to say thank you so much, Pratima and Dr. Dipali, for sparing your valuable time and being with us for today. I especially want to thank Dr. Pratima because you were the motivation behind organizing this e-fest, this event, and you are my sunshine to be, because you told that we need some sunshine. So you were my sunshine, I can say that. You were the inspiration, and your words continuously supported us for organizing this e-fest. We got the courage to do this event. Thank you so much from my heart, Pratima. I just want to thank some of all the esteemed speakers and moderators of this all complete e-fest event for trusting it with us and sparing their valuable time and sharing their knowledge. For this, I want to specially thank Dr. Deepali for really moderating so well in difficult times. So thank you so much, Dr. Deepali. And another major role behind the success of this event is our IT department of MIDSR Dental College, Latur. Without Mr. Bickard, who is the HOD of the IT department, Mr. Rahul Jante, and Mr. Hanmant Nalvade, it would not have been possible to conduct this event virtually without their support. I appreciate their meticulous hard work along with Dr. Abhishek Badade and Dr. Amol Badgire. I thank our principal, Dr. Suresh Kamble sir, Vice Principal, Dr. Suresh Kangne sir, for their encouragement and support. I extend my hearty thanks to my friend, Dr. Sarvesha and her team. She supported the entire program right from the day. The idea of organizing this event stuck to me. She is and her team has done excellent job. I would like to mention thanks to Dr. Madhuri for gracefully hosting the event. I also express my gratitude to Dr. Kabir and Dr. Anita, Dr. Rohit Doot, Dr. Sonam, who managed the off-screen screen. I extend my thanks to Dr. Praveen, Dr. Ajit, Dr. Richa, Dr. Rajender, and Dr. Snehal for their valuable contribution. We are just showing some a glimpse of the Endosynergy 2021. After that, Dr. Sarvesha, she will take over the mic. Yeah, just please be with us.
Thank you so much, Pratima ma'am, Dipali ma'am. There's a small token of appreciation for you both. Please accept it with our sincere thanks.
Thank you. Thank you.
I request Dr. Sarvesha ma'am to speak few words.
Good afternoon. Thank you so much, Pratima ma'am, for this wonderful lecture. And we are really fortunate to have such a dedicated academician like you on this Endosynergy platform. I must acknowledge her love and affection for extending support and helpful hand whenever required, and whether it is a professional issue or personal issue, she is always there. So I must say that, ma'am, you have a special place in our heart because of the unique way that you inspire us. Thank you so much. And thanks to dear Dr. Dipali Shah ma'am for accepting invitation and being so wonderful, and especially handling those hurdle periods of our webinar series nicely and revising all the important points that ma'am has covered. Thank you, dear. And
Thank you. Thank you.
delightful
It was
presence.
a wonderful opportunity.
Yes, thank you. And your delightful presence has been incredible. Please, like this only every time. I like your smile very much. Thank you. Then with this 4 days marathon is ending, and Dr. APJ Abdul Kalam stated that the purpose of education is to make good human beings with skill and expertise. And enlightened human beings can be created only by teachers. So we feel very happy that such great teachers across India accepted our invitation and delivered outstanding presentations during these 4 days. And that would open new avenues in endodontics. So I'm grateful to one and all for their invaluable contributions, and I would like to thank all the chairpersons of all the sessions for their valuable insights and cooperation. I must start with Dr. B. Mohan sir, Dr. Sonali Taneja ma'am, Dr. Vinita Nikhil, Dr. Shiv Mantri sir, Dr. Laura Mishra, Dr. Shalini Agrawal, Dr. Vivek Hegde, Dr. Karunakar sir, Dr. Chandrasekhar, and Dr. Shashirekha Govind, and today's presenter, today's speakers, Dr. Sai Kalyan and Dr. Pratima Shinoy ma'am, and today's chairpersons, Dr. Mahima Tilakchand and Dr. Dipali Shah ma'am. So thank you so much from bottom of our heart, from on behalf of all the members of organizing committee. Everything begins with an idea. Me and Dr. Sunanda ma'am coined this idea of national level webinar and decided to work together. It was great to work with the Sunanda ma'am, and she is so inspiring all the time with so much energetic that we have to
Speak immediately.
Inspired a lot. Yes, yes. I just want to say, but one more important thing, that Ken Bleacher rightly said that none of us is as smart as all of us, right? So I just want to say a massive personal thanks to each and every member of organizing team for timeless efforts over the last few months. They are working so hard to make it successful. Special thanks to the team behind the curtains, because we don't see their faces, but their work, they work a lot, day and night they make together. I owe much gratitude to the principals and management of both colleges for their enormous support. And I'm sure that we all are now excited to join and enjoy the upcoming World Endodontic Congress, IFA 2021. So let's come together and enrich our specialty. Thank you so much.
I just want to declare that we are giving the certificate of appreciation to each and everyone who has contributed in our event. It's like all the team. They will be getting the certificates now. And
I believe this is not the end. It's only the beginning of something great. Every new beginning comes from some other beginning's end. It was a great pleasure, and I feel blessed to host this event and to be a part of it. Hope we get such great opportunities in near future to organize such events with other stalwarts of our field. I once again thank everybody behind the success of Endosynergy 2021. I extend my special thanks to Dr. Sunanda ma'am and Dr. Sarvesha ma'am for having faith in me and giving me this opportunity to host this great event. Dr. Sarvesha ma'am has been a major source of inspiration to me because in spite of facing few personal problems right just before the beginning of the program, she managed to give the welcome address with such a big smile on her face. It was a major motivation for me. Thank you so much, ma'am. Thank you, Sunanda ma'am, for managing all my panicky moments. I declare that the program eFest Endosynergy 2021 is concluded with a grand success. Thank you, everybody.
Thank you, ma'am. Thank you all.
thank you.
Bye. See you.
There is a Pasaidan.
बोलते पाहुना सर्व सुखी पूर्ण होई केही लोकी अहिदो आदि पुरुषी अखंडित आणि ग्रंथोपदी विशेषी लोकीये दृष्टादृष्ट विषय